Good morning. Beautiful morning here in Colorado. It's like this every day, even like February. So uh, wanted to welcome all of you again. For some of you, it might be the third day of the program. Appreciate you guys hanging in there. And we have no live cases today, but we are planning to do these didactic sessions in the agenda and have plenty of time, I think, for question and answers, maybe some that weren't answered yesterday or the day prior to that. Our faculty will kind of be trickling in depending on the sections that they are involved with. So if you do have questions and to a particular topic within those sections, we can address those at the end of each of the sessions. And the different sections I think we have is pancreatic, liver, biliary, colon, esophagus, stomach, just the very generic things. But the topics themselves are phenomenal and the speakers are even better. So I really am excited about that. So on behalf of my course directors, Dr. Wani, who will not be able to be with us today, and Dr. Deloy will be with us later this morning, wanted to welcome you. We have some housekeeping announcements that in order to be eligible for course credit, just a reminder to sign in each day, and there'll be a link to the course evaluation that's posted on our website, that rmiecourse.org or .com, one of the two. The .com, thank you. And the QR code can also be found at the registration desk. Please fill out the link to collect the type of credit that you want, including the nursing contact hours. And for physicians and nurses, just a reminder, you'll receive your certificate within 3 weeks after completion of the evaluation form. And I just want to emphasize something about the evaluation forms is that we look at every single comment, both good and bad, about the conference because we're here to provide an education for everyone. It's about improving ourselves and improving the care that we deliver to our patients. We actually take that very seriously. So please do take some time to fill out those evaluations. And for fellows on a travel grant, your institution will receive travel grant after completion of your evaluation forms and do the daily sign-in at the registration desk. The vendor passport is still going. You still have chance to visit 10 exhibit booths, get stickers, and then if you get to 10, then you'll be entered into a drawing, which we'll do, I think, at the end of the session, I think. And then you're eligible to receive one of 5 $100 Visa gift cards. Look around you. The odds are better than the lotto for sure. The syllabi are available on the rmiecourse.com webpage. And then we talked about asking questions. I'd really encourage you. I know that some of you rather just send the chat questions, and that's fine. We'll address those too. But if at all, you could use the microphone. Christy Click or another staff member will be walking around with a microphone. You can raise your hand and you can ask the question that way. So we would love to hear from you. Wear your name badge every day. And then I just want to thank our supporters. I think yesterday I didn't get a chance to individually thank them, but the supporters of our course include AbbVie, Boston Scientific, Castle Biosciences, CDX Diagnostics, Cook Medical, Irby, Interspace Diagnostics, Medtronic, Merck, Merit Medical, Microtech Endoscopy, Olympus, Avesco, Sanofi, Steris, Takeda. So without further ado, we are going to be introducing the first session, I think a little bit early, but I want to introduce my co-moderator, Dr. Sandeep Latakia, who's going to join me at that moderator desk. And then we're going to begin with our first lecture from Dr. Usma Siddiqui. I've known Usma for more than 10 years. I can't believe I said that. Professor of Medicine, University of Chicago, the director for the Center for Endoscopic Research and Therapeutics and Advanced Endoscopy Training in Chicago. Usma, She'll be speaking on pancreas cysts.
Thank you, Raj, and I want to commend you and all the course directors for putting on a fantastic course. I think the live cases yesterday were amazing, and I look forward to discussing them again today. But for right now, I'm going to discuss pancreatic cysts. I got a lot to cover in 15 minutes, so we will jump in. You know, nowadays, if anyone goes to the ER and they complain of belly pain, neck pain, finger pain, it doesn't matter. They're going to get a CAT scan. And then invariably, they're going to find in a certain percent of the population, you'll find a pancreatic cyst. And now the question is, what are you going to do about it? Well, there's different studies out there that say if you were to scan every single person in the US, you know, anywhere from 2.5% to 10%, depending on your age, you're going to find a pancreatic cyst. So we're talking millions of cysts that are found every year, but a small minority are ever going to be associated with cancer. So only a couple 100,000 will be something that you have to worry about. And the question is, how do we identify those cysts that have malignant potential? I think it's important just to know what are the different types of cysts that you want to think about. The vast majority are going to be associated with a patient who had pancreatitis in the past, and they're going to be pseudocysts. And then if it's not that, you'll start thinking about these other cystic neoplasms like IPMNs, serous cyst adenomas, and mucinous cystic neoplasms. And we'll go through some of those in a little bit of detail. Now, for me as an endoscopist, I like to keep things pretty simple. And when I find a cyst, I just want to put them into two big categories. Is it a mucinous type cyst? Or is it a non-mucinous type cyst? And the reason that matters is because if it's a mucinous IPMN or MCN, those are cysts that you're going to either monitor or potentially advise the patient to get surgery. Or if it's non-mucinous, you can reassure the patient and potentially not have to do anything about it. So in terms of the different types of cysts, I'll just briefly describe some classic traits about each of them, and then we'll get into how we make the diagnoses. But for IPMN, main duct IPMN, those tend to be a little bit older patient category. It's a minority of all IPMN lesions, but most of these patients will have some sort of symptom, mild pancreatitis, belly pain, and most of the time they're going to be located in the head. The tip-off to starting to think that this is the diagnosis are patients where you see a really dilated pancreatic duct, more than 10 millimeters, a fish mouth ampulla, which is secreting mucin. Cytology we'll talk about later is not that helpful most of the time, but if you get mucin producing columnar epithelium, that can give you the diagnosis. Here, the important factor is that most of these are dysplastic lesions, and if they're not cancer now, they soon will be, and they have a high rate of progression. So that's why you would recommend surgery for all of these if you make the diagnosis. And this is an example of main duct IPMN. You have a cystic lesion with solid growth inside of it, a dilated pancreatic duct upstream from the cystic lesion. And if you sample that solid component, as we did in this case, the patient did have a malignancy, and that's mucin coming out of the main ampulla there. Now, side branch duct IPMNs are a whole different entity. We call this a disease of technology. These are those incidentally found cysts and accounts for the vast majority of IPMN lesions. Most are asymptomatic. They can be anywhere in the pancreas. Oftentimes it's a multifocal process. And here the tip-off for the diagnosis is that you have a normal caliber pancreatic duct and it's not dilated. And these are slower growing, perhaps have an annual incidence of progression that is less than 2%. So we recommend surgery for some of the patients. But who would we recommend surgery for? What are some of the worrisome findings? There have been older surgical studies that suggested if you have a mural nodule or growth inside of the cyst, or a cyst is more than 3 centimeters, those might be risk factors for progression to malignancy. And these come into play when we talk about guidelines. Mucinous cystic neoplasms almost exclusively occur in women. a little bit younger age group. Most are asymptomatic. Most often they're located in the body or tail of the pancreas. And they have these septae without any communication to the pancreatic duct. Ovarian stroma and cytology, again, you don't get it that often. But if you can definitively make the diagnosis, you would recommend surgery. And then serous cyst adenomas are kind of the best case scenario when you get referred a patient who was told they had a pancreatic mass. These are lesions that are basically what we call microcystic or have a honeycomb appearance. Sometimes on imaging, they'll have a central scar. And if you have these characteristics, it's pretty classic for making the diagnosis, but there is an oligocystic variant that can be confused with other types of cysts. But these have very low or no malignant potential. So most of the time you just observe unless they're really large, or if you don't know what the diagnosis is, say it's in the tail and you don't know if it's a mucinous cystic neoplasm or serous cyst adenoma, the patient might go to surgery in those cases. And just a couple other types of cysts, cystic neuroendocrine tumors oftentimes have this kind of eccentric wall thickening that if you biopsy under EUS, the wall, you'll get a diagnosis. The treatment for those can vary from just observation to enucleation to surgical resection, depending on if the patient is symptomatic or not and the size and location. Young women in their 20s, 30s that have a solid cystic lesion in the body and tail, almost always it is a solid pseudopapillary tumor, and patients do very well if they undergo surgery. Again, here EUS FNA with cytology will get you the diagnosis. So how do we make the diagnosis? I think for a lot of these cases, if you just look at your patient, is it a man, woman, how old are they, have they had a pancreatitis or not, you can already start making a differential as to what type of cyst you're thinking about. And then what are the cyst characteristics on imaging? CT, MRI, and EUS are some of the most used tools. And obviously with EUS, you have the ability to sample the cyst. CT and MRI are pretty equivalent in terms of overall diagnostic ability. We use MRI probably more often because with MRCP in particular, you can get details on communication with the pancreatic duct. There's no ionizing radiation. And with an MRCP, you don't even have to give IV contrast. So you can get a really nice ductal anatomy picture. EUS can sometimes pick up more cysts in different locations, which might have surgical implications. You can identify septations. Is there a background of chronic pancreatitis and any worrisome findings? And obviously, again, we can sample them. The problem is if you have these unilocular type cysts, then just looking at it under EUS has probably a 50-50 chance of making a diagnosis. So that's when we start talking about aspirating a fluid. Now, cytology results are variable, probably around 50% yield because these cysts are acellular and you don't have that many cells to analyze, but we do it. CEA is far from perfect. And again, it's not an indicator of malignancy. It's just to try to differentiate mucinous versus non-mucinous cysts. And then depending on what cutoff number you use, your specificity for a mucinous lesion can be as high as 98% if you're looking at really high numbers. But usually we'll use a cutoff of around 192 based on an old study by Bill Brugge. Fluid viscosity, you saw yesterday in a live case, we did a string sign, which is a nice, quick, easy way to identify a thick mucin. And it's a little bit better than CEA because you only need a drop of fluid versus CEA, you need a whole cc of fluid. And then fluid glucose, if it's less than 50, then that has a high sensitivity and specificity for mucinous lesions. So these are probably the basics that are sent on cis fluid up front. Amylase we also send, and all that's going to tell you is that there is some sort of communication with the pancreatic duct. So an IPMN lesion and a pseudocyst can all have high amylase. So this is a very short summary on all the different characteristics of the types of cysts. But even taking all of this into account, we're probably around 70% accurate for making our diagnosis based on what's available routinely. So then what else can we do? You can get a little bit fancier and start doing things like confocal laser endomicroscopy, where the patients are given IV photofrin and then a tiny laser probe goes through a 19 gauge needle and you try to look at the lining of the cyst. And our group with some of the studies where we showed that if you were lucky enough in your couple micron view to get the one perfect picture, perhaps you'll make the diagnosis, but it's kind of a crapshoot, and that's why the sensitivity is not that great. So, but we don't do the routinely. Yesterday you saw us, we used the microforceps, and some studies have demonstrated higher diagnostic yield when you combine it or compare it to FNA. But you did see a little bit higher complication rate with bleeding and pancreatitis. But this you saw yesterday as well. And again, you need a 19 gauge needle. And the only thing whenever you're using 19 gauge needles, those are stiffer needles. Your tip deflection on the EUS scope changes. And sometimes if the lesion's in the head or the uncinate, it may be harder to get your needle and devices out. Molecular testing, everyone's really excited about it. Number of studies looking at different markers, not only to differentiate mucinous from non-mucinous cysts, but also trying to identify those cysts that are going to progress to malignancy or have malignant potential. But for right now, most of this is all being done under study protocols. It's not paid for by insurance. And again, it's not readily available in every center. So it's something promising for the future, but we're not doing it routinely. So whenever doctors don't know 100% what to do with something, they come up with guidelines. And in the field of pancreatic cysts, there have been innumerable guidelines over the last, 15 years or so. We're getting closer, I think, to being a little bit more accurate in terms of which cysts to worry about. But these are probably the three most cited guidelines by a lot of endosonographers. I like the ACG 2018 guidelines because they're very clinically oriented. But the features that I already talked about that are worrisome for lesions that might have malignant potential, that dilated PD, the solid component, the large size, significant cyst growth, those are all things that are worrisome. MRI and EUS are going to be your main imaging tools. And once the cysts get bigger or have high risk features, probably their patient's going to have an EUS with sampling. And if you can confirm a serous cyst adenoma, you could potentially stop surveillance even. So I think that saves a lot of anxiety and healthcare dollars in terms of follow-up imaging. And EUS guided ablation is one final topic I'll mention. There've been a number of studies looking at alcohol ablation, where you can aspirate the cyst and then lavage with alcohol, plus minus with a chemo agent. A number of studies in the past have shown variable results in cyst resolution, but they've also showed complications, pain, pancreatitis, bleeding. So it's not necessarily done that often. EUS guided RFA was discussed yesterday in the live cases, where you have, in this case, an FNA probe that has an ablation tip. And then depending on the size of the lesion, you can ablate your cyst or mass. There's not that much data on this. This is probably the biggest study from Bartet out of France with, under 30 patients that they looked at with neuroendocrine tumors and cystic neoplasms. For neuroendocrine tumors, after 3 years, maybe an 86% success rate. With regular cystic neoplasms, only a 40% success rate. So you have variable success rates, but what you did also have for these supposedly benign lesions were significant complications, pancreatitis, bacteremia, perforation, to the point where they changed their protocol for doing these ablations. But, again, it's hard to say, is it worth the treatment to have these potential complications? So while, ablation's advantageous over surgery because you're preserving the organ, and it's easy to do. Disadvantages, we don't know long-term resolution rates. Right now, it's suggested for small lesions less than 2 centimeters in size. You have the potential to have all these serious complications for likely cysts that may not cause any problems. I will say maybe in those symptomatic insulinomas that are smaller and not patients that are not surgical candidates, it may have a role, but most often this techniques is performed under study protocol. So, my approach to pancreatic cysts, the vast majority of cysts are benign. So I think, the first thing I have to do is reassure the patient. Most of the time, you're going to find side branch IPM. We're doing a lot of surveillance for these patients. It's similar almost, to Barrett's. Not everyone with Barrett's gets esophageal cancer, but not everyone with a pancreas cyst is going to get pancreatic cancer. So things to consider: your patient, look at them, get a good history. If someone's 90 and has a 4 millimeter pancreatic cyst, who cares? Like, you don't need to keep scanning it or refer it for an EUS. If the patient's never going to go to surgery, then why are we doing surveillance? If the cyst is really small, less than a centimeter, does not need an EUS. Realistically, if they're between 1 and 3, likely they're going to get an EUS. And if they're over 3 centimeters, any worrisome or high-risk features, they're going to get sampled by FNA. And also, is it one cyst in the tail versus multifocal disease? Because that's going to have implications for surgery. If there's any worrisome findings, I always discuss these with my pancreatic surgeon. And so, when you find these cysts, your goal is to try to classify them to determine malignant potential and counsel your patient. MRI and EUS are going to be your most useful tools. You can analyze the cyst fluid to help make that diagnosis and then use the guidelines kind of in the context of each patient. Right now, ablation and molecular analysis of cyst fluid is not routine, but I'm sure more to come in the future. And I invite everyone to Chicago in August, the 1 month where it is weather like Colorado. All right, thank you.
Thank you. Thank you, Usma. That was excellent. We'll reserve questions for the end of the session.
Hello, do you hear me? Let me invite the next speaker. Please join us. Am I audible? Hello, can you hear me? Yeah, okay. Josh Obuch is a new friend of mine. He's director of endoscopy at Gensinger, Wyoming Valley Medical Center, Pennsylvania. Josh,
Thanks. Good morning, everyone.
that's the effect of last night.
Thank you so much. Nice to meet you as well, Dr. Laktaktia. So today I've been burdened with the task of talking to you guys over 15 minutes about the management of walled-off necrosis. So I have no disclosures this morning to reveal. So when we talk about necrotizing pancreatitis, it's in the setting as a sequelae of acute pancreatitis, with the annual incidence of pancreatitis being relatively high and a burdensome pathology in the United States, accounting for up to about 38 per 100,000 person years for annual incidence. And the findings of acute pancreatitis can be either interstitial and edematous or necrotizing, where there's death of the organ itself. And about up to 20% of patients who suffer from acute pancreatitis can develop pancreatic necrosis. And of those patients with pancreatic necrosis, up to a third of them can develop infection, which can lead to increased morbidity and mortality in terms of disease management and patient outcomes. And when we have patients with necrotizing pancreatitis, optimal management really requires a multidisciplinary approach, including advanced therapeutic gastroenterology, surgery or MIS surgery, interventional radiology, critical care, nutritional management, and infectious disease. Just a brief review of collections. You should all be familiar with the Atlanta Working Group classification of fluid collections and sequelae of acute pancreatitis. But when we're talking about fluid collections or findings around the pancreas in the setting of acute pancreatitis, in patients who suffer from acute interstitial pancreatitis, they can have in the early onset phase acute fluid collections without any necrotic or solid components. And if these do not resolve within the next 1 to 4 weeks, they can mature into a pseudocyst, which is a fluid-filled inflammatory collection. Alternatively to that, if a patient suffers from acute necrotic pancreatitis with death of the parenchymal pancreas parenchyma, this can mature into a walled-off necrosis, which is essentially the counterpart of a pseudocyst with solid components. So when do we consider drainage for these patients? Acute fluid collections and acute necrotic collections rarely require drainage and may resolve spontaneously a lot of the time. However, if patients are developing symptoms in the setting of maturation of these collections, indications include persistent pain, concern for gastric outlet obstruction, failure to provide enteral nutrition because of gastric outlet obstruction, possible biliary obstruction from mass effect of the collection, or concern for an infected collection seen with air or sepsis findings after a patient has been hospitalized for several weeks. When we have options for necrotic collection management, there's endoscopic transmural drainage, which we'll focus on, but there's other non-endoscopic options that are also available that you should be familiar with, including percutaneous retroperitoneal or transperitoneal drainage, minimally invasive retroperitoneal necrostectomy, video-assisted retroperitoneal debridement, or VARDS for short, or laparoscopic or open necrostectomy, which should really be reserved for last resort or extremely unstable patients who are unfit for any of the above. So when we talk about the approach to drainage, what we call a step-up approach has been recommended with data to support it over time. About 10 years ago, there was a randomized trial called the Panther trial, which randomized patients, 88 patients with infected walled-off necrosis to primary open necrostectomy versus a more conservative step-up approach. And what they found was that early surgical intervention had worse outcomes compared to percutaneous or internal drainage. And the major complication rate in the step-up approach was around 12%, with open surgery being around 40%. What was interesting was that there was a similar death rate between the two groups, suggesting that the minimally invasive approach was not undertreated. These patients were still very ill and getting maximum therapy. A small randomized controlled trial of about 20 patients called the Penguin trial compared endoscopic transgastric drainage with video-assisted retroperitoneal debridement as necessary versus open surgical necrostectomy, and similarly reduced major complication rates with the minimally invasive approach. And then there's been multiple retrospective data comparisons to support a step-up approach. There's been pooled analyses of close to 2,000 patients comparing open minimally invasive surgery and endoscopic drainage techniques, and lower mortality rates have been evident in patients going through the minimally invasive options. So when we think about drainage, the decision of how and when to treat is dependent on the collection location, extent of the disease, equipment availability, and expertise at your institution. The AGA, just for reference, has amazing guidelines, clinical guidelines to kind of show for you through the management strategies. But in the acute phase, we really just focus on supportive care, management of possible SIRS criteria, possible infection with antibiotics if you're concerned, pain symptom management, and nutrition management. But as these collections start to organize or mature and have more opportunities for drainage, you need to start to consider drainage options, and your approach should be dependent on location of those fluid collections and the availability of assistance at your institution. I'll skip over that. So when we talk about endoscopic ultrasound-directed drainage, really it's you have to review your imaging and plan your approach. You know, what is your access window? Do you have a transgastric approach? Is it going to be a transduodenal approach? Does the patient have a large paracolic section that you don't think you're going to be able to access endoscopically, and you may need to get your interventional radiology colleagues to help or get surgery involved earlier on? But when we're considering drainage from an endoscopic approach, I usually provide patients with prophylactic antibiotics, and I usually will plan for drainage on the fluoroscopy table. For drainage techniques, we use endoscopic ultrasound, and having a therapeutic linear echo endoscope is necessary for doing what we need to do. And we can evaluate at time of ultrasound for any overlying vessels or any critical structures that may be in the way of our drainage that we don't want to call iatrogenic injury to. And then you can access the collection for drainage once you have an appropriate window. Traditional methods for drainage really were cumbersome. You know, you'd have a patient on the fluoroscopy table, 19-gauge needle, get wire access to the collection, have to make a fistulous connection using an electrocautery device such as a needle knife or a cystotome, and then get dedicated wire access, potentially inject contrast in the collection to define the boundaries of the collection, dilate that fistulous connection once you've made it, and place a stent. And any step in this process is an option for failure and complication. So it was very time consuming, and it was very stressful for the endoscopist. Now in 2024, in the last 10 years, has been the advent of the electrocautery enhanced lumen opposing metal stents. And essentially these combine all those steps into one device. So you have access, dilation, stent deployment, all in one device, which has greatly shortened our amount of time necessary to access these collections and intervene as necessary. There are multiple sizes available in the United States, and they really range mostly in size of the usual size that we tend to use for endoscopic drainage is a 15 by 10 or a 20 by 10 at our institution. So when we're using lumen-opposing metal stent, first step is access to the collection. You step on the electrocautery pedal with the needle once you found an appropriate window and get into that walled-off necrosis. The next step is the extraluminal flange deployment that is on the stent there by pulling back the sheath. And then as you're deployed the extraluminal stent, you have to approximate that stent to the wall of the collection as close as you can reasonably to the stomach or the duodenum and the collection itself. And then there's intraluminal flange deployment. The manufacturer recommends that you visualize a black band on the device when you're pulling back endoscopically, which can be very difficult. So I usually deploy within the device itself and then push the stent out. And then once you have stent deployment, you can dilate to promote drainage of the collection. But here you see we have a transgastric access to this walled-off necrosis, looking at that kind of clotted, nasty garbage right there. EUS direct access with single stent is usually sufficient. Large multiloculated collections may require different access points to facilitate drainage, known as multiple transluminal gateway technique, or MTGT. There's a study in 2011 that compared this process over conventional transmural single-use stents with nasocystic drain and pigtail stents. And what they found was that multi-gate access was successful 91% of the time and did not require surgical intervention versus 52% of the time when a single access point was used. And so we've kind of taken this data and used it for our lumen-opposing stents. Here you see a patient that we had at our institution with a large necrotic collection where we placed 3 lumen-opposing metal stents across the stomach in 2 positions and across the duodenum as well to facilitate access to this large collection and improve debridement and necrosis drainage. And so here's another patient that we had left. You could see there are walled-off necrotic collections around some viable pancreas in the middle there. And then we placed 2 transgastric lumen-opposing metal stents with coaxial double pigtail stents. And patient followed up with a week and a half for a necrosectomy. And after an hour and a half necrosectomy, his collections were resolved. So we were able to manage this patient in 2 sessions, which may have taken more sessions if we only had 1 single access. When we talk about endoscopic necrosectomy and mechanical debridement, the goal is really removing as much necrotic tissue as possible within the cavity. And what do you use? I use whatever works. I mean, honestly, there's nothing really that's on label that we use for necrosectomies that's been developed strategically for necrosectomies, but I tend to use large grasping forceps or snares. Other physicians may use baskets, nets, tripod graspers. But once you have that lumen-opposing stent in there, you can access this collection after it's had time to mature and fistulize and work on debridement for the solid components that need to be removed from the cavity itself. There are 2 devices on the market that have been published or produced to kind of focus on the issues with necrotizing pancreatitis debridement. One's the endorotor and the other is the excavator. The endorotor is a rotating serrated tip on a hollow catheter system connected to an independent suction system. And it's operated by the endoscopist. There's a rotating blade essentially in there, and then a suction vacuum component. And it really helps with patients who have this liquefactive necrosis within the cavity. I kind of describe it as like wet sand, where you're trying to grasp it and it's just like trying to eat soup with a fork. You know, you just can't do it. And so this is kind of helpful where you can suck up some of that liquefactive necrosis and kind of less organized components of the necrotic collection, and you can debride at the same time. So some early data in small studies to suggest that it can shorten duration of your necrosectomies as well as how many interval necrosectomies that you need to perform. Another device is known as the excavator. This is an over-the-scope device, single-use extra-large grasper attached to the tip. It's fairly large. It's about 14.5 millimeters in diameter when it's closed, and it can be close to 3 centimeters when the tips are open. And its volume of accommodation is about close to 1 cubic centimeter. So it's essentially like a shovel. I mean, it's if you can use it for large collections or you have to make large purchases on the collection, it does work well if you can get into the collection and access this or have availability to this device. There's also a hollow tip in the middle so that if you have large necrotic components, you can kind of flush through your endoscopy channel and or put a wire through to poke out some of that dead tissue. But when it works pretty well. I don't routinely use this in my practice, but I know some physicians in my group do use this and have had reasonable results with it as another tool in their toolbox. But here you can see taking up a chunk of dead necrotic tissue, scooping it out, and then repeating the process. So there's also the options of chemical debridement. So Hydrogen peroxide can be used to facilitate necrotic tissue sloughing and has antibacterial properties. So at the conclusion of necrosectomies, I will sometimes also fill the cavity with a diluted hydrogen peroxide solution, about 150 to 300 cc's. And there is some retrospective studies, which I believe University of Colorado was a part of, suggesting increased clinical success and time to resolution compared to no hydrogen peroxide usage, with no difference in adverse events noted when using this chemical debridement strategy. There's also anecdotal usage of using Coca-Cola. I tell patients in between their procedures to, if you like Coke, drink a can of Coke or two a day to help with chemical debridement. I learned that from Dr. Ed Mundwitz when I was a trainee here. But this is really extrapolated from gastric phytobutazore dissolution data. We know from patients who have phytobutazores, there has been Coca-Cola used for chemical debridement. And if it can take rust off your car wheels, it could probably break down necrosis as well. But there's no good data to this. This is only anecdotal. I don't have any data to support that. And then additionally, we hold proton pumps in these situations because the gastric acid in patients can percolate through the collection and help break down some of that necrotic tissue and help in debridement as well. In terms of how long this should take you, average procedures for clearance has been reported in meta-analyses to take upwards of about 4 procedures. And I tell patients the average time this is going to take to resolve your collection is going to be 4. You may have to come back and forth. We'll try to manage you as an outpatient if possible, but it may lead to increased length of stay. Sometimes these patients are critically ill and can't leave the hospital due to their necrosis. But at each interval necrosectomy, they do tend to improve more and more and get stronger if they're not if you're managing the infectious complications and staying on top of their management. There are procedural complication rates that have been reported up to about 20%, including bleeding, infection, as well as injury to the wall of the necrosis, leading to a perforation that could lead to emergent surgery. Bleeding and sepsis are by far the most common. Perforation, if you're careful, you can hopefully avoid a perforation, but something to quote your patients on as well, because that could lead to an emergent situation. And surgery for management of these strategies has been reported to about to be 13% of the time. So even with our minimally invasive techniques, we still may need to get our surgeons involved to assist with collections that we cannot access or patients who are not improving. So when we talk about debridement, there are some challenges. Blind grasping and you're getting the collection can lead to bleeding. And when you see bleeding that can happen, epinephrine use can help stabilize a vessel that you might hit. Coagulation graspers can be used in the cavity. Clips have been used as well. In emergent bleeding, if there's injury to a pseudoaneurysm or a splenic artery that you cannot control and there's red out, IR embolization or surgery may be necessary. Other issues that we can run into is firm adherent necrosis. These collections can be very tenacious, and our ability to grasp and remove the collection can be complicated by just the solid nature of some of this dead tissue and may require surgical resection if we can't get it. We talked about that liquefactive necrosis, like removing soup with a fork. And then these are cumbersome procedures. I mean, usually when we plan for a necrosectomy, this isn't a half hour, this is kind of block off 2 to 3 hours and anticipate to be there for a while. So, you have to bring these patients back every few days to weeks and chisel out enough time in your endoscopy schedule to be able to effectively work on the collections and help with mechanical debridement. Lastly, I want to talk about post-debridement. There is concern for potential disconnected ducts. So in the setting of necrosis of the pancreatic parenchyma, you may have a complete ductal injury that can lead to pancreatic disruption that may not be evident at the time of your interventions and management of these patients. And it can happen up to 50% of the time. There can be incomplete ductal disruption or injury to the duct from necrosis, or complete disruption where the duct is completely transected with such as a body necrotic injury where the head and the tail are viable, but there's nothing in the middle to bridge that gap. So sometimes if there's incomplete disruption, we can manage that with transpapillary stenting. Personally, I've used MRI to look at the pancreatic duct and degree of necrosis after we've completed necrosectomy to determine whether or not we need to keep a permanent plastic pigtail stent transgastrically to help with any type of injury to the pancreatic duct that may lead to a recurrent fluid collection if we were to remove all sorts of transluminal drainage. And then in certain situations, it may require pancreatectomy or Roux-en-Y drainage from your surgical colleagues. So I just have 2 quick case presentations to review. I have a 50-year-old male who was admitted to our institution with biliary pancreatitis. He had a CT scan after his initial presentation that showed concerns for acute necrotizing or acute necrotic collections, evidenced here in the middle of the screen. He was treated supportively, fever management, pain control. He was tolerating food and felt generally well after a few weeks or a week in the hospital. And so because he was doing so well, we were planning for outpatient management for this individual and follow-up CT scan in about 2 to 3 weeks. He was asymptomatic, but surgery saw that he had a large collection around his stomach. This patient, I was like, anything? Yeah, are you vomiting? He goes, no. Fevers? No, I feel good. No, nothing. So I was like, all right. So surgery requested that we needed to get his gallbladder out prior to them removing or get his collection under control before they took out his gallbladder. So we wound up doing a lumen-opposing metal stent drainage, and he had interval necrosectomies with clearance of the cavity and a double pigtail stent placed. And then we removed his pigtail 1 month later because everything looked good. And this was earlier on in my career where I did not get an MRI prior to doing this. He had his gallbladder out, and then he came to us 6 months later complaining of early satiety. And here you go. He has a large fluid collection that happened from duct disruption in that setting. So we were concerned for a disrupted duct and discussed endoscopic management strategies. He wanted to try transpapillary approach. We were saying that we may be able to bridge it or get into that collection. We did ERCP. You could see that in the head of his pancreas, there was fibrosis there, and there was no bridging to the tail. There was no way to bridge this transpapillary because there was no ability to wire access his pancreatic duct. So we wound up doing a transgastric approach, placed a large guide wire into the collection and left him with a double pigtail stent for collection resolution of this mostly fluid collection. And there you go. After double pigtail stent drainage, his collection resolved. He felt well, and we left him indefinitely with the double pigtail stent to manage this disruption. Now, usually we'll leave them in permanently. They may push out or fall on their own, but I haven't had issues with running into issues with patients having these retained pancreatic stents. They're soft, they're malleable, and they allow a fistulous connection for that disrupted duct to connect to the luminal GI system for drainage, so they don't have recurrent fluid collections or necrosis. And then my last case here is a 72-year-old man who was referred to my hospital with acute biliary pancreatitis in the setting of severe necrotizing pancreatitis. Very pleasant gentleman. He had clinical decline despite maximum supportive care in the intensive care unit. He had repeat imaging 3 weeks after his initial presentation, and there was concern for infection with air within the necrotic collection. Did not look mature enough at this point for us to do any type of endoscopic drainage. So we had our IR colleagues place a percutaneous drainage. And then after resolution or after maturation of the collection, we performed direct transgastric access following his percutaneous drain. But here you can see a lot of gas in that collection there. So we placed a lumen-opposing metal stent, and there's some air in there after we've created that transgastric access. He underwent multiple interval necrosectomies with lumen-opposing metal stents, and then we took out his lumen-opposing metal stents and replaced them for double pigtail stents for placeholders, transduodenal access. He has stents coming out everywhere. So we were really trying our best to endoscopically manage this. And he was having persistent pain, nausea, despite percutaneous washouts and necrosectomies. And what we encountered was that he had this just massive, tenacious, large necrotic area that I was actually using endo scissors to try to cut and pluck this out. And after 3 attempts and we were getting nowhere, we got our surgical colleagues to try to do video-assisted retroperitoneal debridement. So they were able to get access to the collection and pull out his dead pancreas, essentially. So this is what our surgical colleagues were able to remove, and he had improvement of his fevers and pain control. He had an MRI performed post-video-assisted retroperitoneal debridement with noted viable tissue in the tail and parts of the head onset it, but no visualization or viable pancreas in the body, concerning for a disrupted or disconnected pancreatic duct. And so we left him with a transgastric 7 French by 10 centimeter drain. I follow him up annually. This man's doing amazing. So in summary, necrotizing pancreatitis can lead to significant morbidity and mortality, and the management of these collections really requires tertiary level interdisciplinary collaboration. So you really need to have that advanced endoscopic techniques, but in addition, you need IR and surgery. You need to have a good ongoing conversation with your colleagues to help manage these patients in a multidisciplinary approach. And endoscopic drainage really should be our first option when feasible, with a step-up approach pending response to therapy, with surgery as a last resort to prevent further morbidity in these patients, and then anticipate the potential for disconnected duct and management strategies moving forward. So thank you for your time and attention. I appreciate it.
Thank you, Jeff. That was excellent. Great to see you doing such amazing work. You make us look better than we really trained you to be. So I think we have our next speaker that'll be joining us from Italy, I believe. I mean, I know he's from Italy, but whether he's joining us is a different question. There we go. Okay. So Dr. Alberto Larghi is joining us from Gemelli Hospital in Rome, Italy. Thank you so much for carving out part of your afternoon to join us today. And Alberto will be speaking on the ERCP and EUS for postoperative pancreatic strictures. And welcome.
Hi, everybody. I don't know. I think I'm not able to the screen because there's somebody else. So thanks for the invitation and thanks to all the friends who text me and send me emails, and a particular hi to Marco Del Chiaro. I think he's there and he's gonna
He's
present.
waving hello to you.
Yes. Okay, so let me see. Yeah. 1 second. Too many things. Okay, so we'll start from surgery. So we'll talk. I will try to talk to give an overview on the treatment, endoscopic treatment of post-operative pancreatic strictures. So what drives the symptom is usually, as you can see from the MRCP on the left side, this is a post-Whipple PD stricture, is ductal hypertension. So the mainstay of treatment, I don't know why it doesn't go. Okay, so the mainstay of treatment is ductal drainage. And as we know, the conventional endoscopic therapy has high rate failure rate due to unsuccessful access of the pancreatic duct. These are all the type of endoscopic treatment that can be utilized in post-operative pancreatic strictures. So this is the old one, the ERCP. The one is done with the ERCP scope. This is a mistake. So this is a US scope, but should be an ERCP scope. There is the balloon-assisted endoscopic treatment, and then there is the US guide that can be a rendezvous. So a US guide wire in the jejunum, and then is reached by ERCP, and so there is a rendezvous procedure, and then there is transmural drainage that we'll see how it can be done. So the approach, the old approach, the ERCP, with the one performed with the ERCP scope is characterized by a difficulty in reaching the papilla. With the high failure rate, and usually the procedure are very, very, very long. So the single or double balloon enteroscopy has largely substituted the ERP approach. However, if you look at the literature, the technical success rate range varied from 8 to 70% of the cases, and cannulation of the PJS stenosis can remain a big challenge. So regarding the US treatment, so it can be done with a rendezvous, as in the upper figure on the left side, or with transmural drainage. Is a technically challenging procedure, and should be performed in selected high volume centers. And it should be contraindicated when clearly the PD is not cannot be visualized, when there are intervening vessels, or when there are multiple MPD strictures. So it's very important to drive this procedure that can be at high risk with an imaging before, in particular with MRCP. So the rendezvous procedure starts with assessing the PD with a 19-gauge needle that is preloaded with contrast. So you perform a pancreatography. Then you advance the guide wire. In some cases, it is able to go through the stricture and goes into the bowel. And when it goes into the bowel, the guide wire is grasped and is brought back into the channel of the echoendoscope. Echoendoscope that then is substituted with a ERCP scope. And with the ERCP, you place a plastic stent in the main pancreatic duct. Regarding a transmural drainage, is it possible to perform a gastropancreatic enterostomy? So this is a 59-year-old male with a pancreatic duodenectomy for IPMN, with a stented pancreatic gastrostomy that subsequently became stenotic. So the procedure is the same: 19-gauge access and then pancreatography. In this case, the access, the fistula tract is then enlarged through a cystotome, and the guide wire advances through the surgical PG. So subsequently, the PG is dilated, so the stenosis is dilated with a 4-millimeter balloon, and a double pigtail plastic stents with bidirectional drainage is placed in the stomach, the so-called ring drainage. This is a video that Sandeep gave to me with the courtesy of Sandeep. So this is the picture of gastropancreatic enterostomy that starts with the access of the PD with a 19-gauge needle, preloaded with contrast. So this is the pancreatography. Clearly, there is a stricture with some contrast that is able to be goes into the jejunum. At this point, the tract is enlarged with a 6 French cystotome as before. This is what you see in the US image. So the tract is dilated. The guide wire is passed through the stricture. So at this point, you can place, you dilate, and then you can place a straight plastic stent through the stricture and through the gastric wall. In case the guide wire doesn't, is not possible to advance into over the stricture, a pancreatic gastrostomy can be done. So let's look at the comparison between the techniques. There are the studies are limited, and it's not only the number of studies that are limited, but also the number of patients who were included in the studies are limited. So the most of the information are gathered from a systematic review. This is a systematic review that compare ERP versus US PD drainage. As you can see, the most important things, the clinical success rate is significantly higher in when the US approach is used as compared to the ERP, so 79 versus 19. So this tells you that probably the ERP approach should not be used anymore. And this is a sub-analysis of the patients who underwent US PPD pancreatic duct drainage. Most of the procedure were transluminal stenting or antegrade dilation and stenting, and only 17.5% were rendezvous. So the rendezvous sometimes can be difficult to navigate the guide wire through the stricture. So more and more physician tends to place a transluminal stent. So what about the balloon-assisted ERP versus USPD? This is a an international multi-center retrospective studies. As you can see, the total patient enrolled was 66 in 7 centers over 68 months. That means 1 patient a month. So this is really a rare condition, and this tells you that this procedure should be done in centers of expertise. And also in this case, the US PPD drainage was significantly more technical and clinical success rate of the enteroscopy approach, at the expenses of a higher rate of adverse events that, however, were reported as mild to moderate. So there were no severe adverse events and no death related to the procedures. This is a Japanese guy who proposed a sort of a step-up approach. So to start with the enteroscopy, so the ERP assisted enteroscopy. In case of failure, to pass to the US guided approach that can be transmural or with the rendezvous. So these are the guidelines from the ESG that are not only for post-operative, but for all PD intervention, for all pancreatic duct drainage intervention that should be done only in patients who are symptomatic when another method is failed or was impossible. Important, something that I already said, that the USPD drainage should be only performed in high volume centers with expertise in the technique because of the high risk of adverse events. And if you have to choose, sometimes it's better to perform rendezvous over the transmural technique because of the lower adverse events. So there's not that much in the literature, so my talk is over. In conclusion, I think that for postoperative pancreatic stricture, the treatment modality strongly depends on the local expertise. So there are places where the enteroscopy is very high and where the procedure are performed with enteroscopy first. In case where US is a strong, the USPD is performed first. And USPD is gaining popularity because of the high success rate and because of the low number of patients who require this procedure. Probably randomized controlled trial or also comparative studies will be very difficult to be performed in the future. So you are all invited to the next global US Skyline event that will be in October 4th, 2024, where we will be transmitting all from Australia to America from 8 a.m. to 10 p.m. Thank you. I want to say something about the patient of yesterday, if I have time.
Yes, please, Alberto. And we were going to ask a couple of questions too. Thank you so much for this talk.
So the RFA patient was okay, no pain. So she was sent. She was discharged home this morning. The other patient started drinking last night. She was okay, but we kept it a little one more day in the hospital just because she had a problem with the lung because she has a Staphylococcus aureus infection. So they are all fine. They are both fine.
Thank you. Is there a way we can show his image, or does he have to stop sharing?
Yeah.
Or we'll try
Yes.
to, if you
I
can.
stopped sharing.
Okay, there you are. Thank you, Alberto. Appreciate the update on the patients. We were going to just take some questions while Alberto has joined us so that he can enjoy his lovely evening in Rome, or in the mountains, one of the two.
No, I'm in Rome. But it's still 4 p.m.,
Yeah.
4:30.
Okay.
And it's sunny, so I still have time.
Any questions from the panel?
Hi, Alberto. It's Uzma. Great talk. I think for the audience, can you just discuss what adverse events that you always think about when you're doing these procedures?
Very nice, very good question, Usma. Thank you. So the main worrisome is that you basically, if you use a cystotome, you cut through pancreatic tissue. No, in most cases, the pancreas is usually he has a chronic sort of chronic pancreatitis parenchyma. But this can generate a pancreatitis, collections, some in the past also perforation. I think now is not an issue anymore. So I think the major concern is it's pancreatitis and pancreatic fluid collection.
And
Then you can eventually, yes,
and some reports with delayed bleeding too from the cystotome.
yes. And the problem is some of the problem is also related to the fact that when you place a plastic stents, then you have to exchange usually every 3 months. Sometimes when you take out the stents, you cannot put it back. It's very difficult. It can be very difficult to put it back in the same place. And at that point, to repeat the procedure can also be very difficult because the duct is at that point is small, is not dilated anymore.
Hi, Alberto. It's Josh Obach.
Hi.
What a great talk there. And I saw your use of a 6 French cystotome. That is not commercially available. It is on?
Yeah.
Okay. Oh, okay. Oh, it is? It just came. Oh, never mind. I have no
Yeah.
questions for you at this time. Okay.
Yeah, has become available.
Yeah, no, as of last summer, Taiwu has
Oh,
the
okay.
6 French cystotome. So, yeah.
It's a little hard to get, but we
Just
just
order it.
recently got
In
it.
Chicago, I'll get you one.
We have one here for the course. In
You
case
know,
it
if you,
didn't
if you
happen.
if you tell me I can buy for you like 20, 40, no problem.
We have a question from the audience, Alberto, if you have a few more minutes.
Good morning. Thank you for this nice presentation. I just actually was about to ask about what kind of tome and or like also the wire for the EOS guided drainage of the PD do you use?
What
Wire-wise.
kind of
So which guide wire
Yeah.
and which instrument do you prefer?
instrument? What does it mean?
I think you meant which you were talking about the 6 French cystotome. That's your preferred method
Yes.
of gaining,
Yes. Yes.
dilating the tract and
The
gaining
the,
access.
the guide wire are usually the 225 from Olympus. Because the problem of the guide wire sometimes it's how you say it doesn't come in English. You know, it peels.
Yeah,
So
it gets
the
stripped.
205 it's almost at the edge of the 19 gauge needle. So if you can if you use the Olympus one that is stiff but smaller, I think it's better than the 035. I don't know, Sandeep, what is your opinion? What is your experience?
Yes, I start with by a Terimo wire, the hydrophilic wire, angled, and then go over cystotome, create that fistula, and then exchange with a longer wire. Because as you rightly said, if it peels, if the guide wire shears off, then you have to start all over again.
But which size do you use?
0 to 5.
Okay.
So we do these procedures here, and they are our least favorite procedures
Yes,
because
yeah.
of how
Yes.
minimally dilated sometimes the pancreatic duct may be. And we do have folks in our audience, practitioners that are physician assistants or physicians that don't perform these procedures, or if they do ERCP, they don't necessarily do this type of interventional
But
EUS.
as I said, you know, the complication rate can be extremely high. And I think, you know, if you don't do it, or if you do one or two a year, it's better if you don't do it. And you send to a center, because you know, you can have a lot of also in good hands, you have adverse events, you know. So also in experienced hands, you can have a lot of adverse events. So I think like for certain surgery, you know, pancreatic surgery and so on. So this should be done in tertiary referral centers.
But some of the question was going to be related to if they work at hospitals where they don't do these type of procedures, but they may work with surgeons that might do pancreatic surgery or general surgeons that do some pancreatic surgery. What is some advice you would give the providers at hospitals where these services are not available as far as
send to
when
a
to
tertiary
consider referral, or do they let the surgeons kind of manage it? Are there certain like guidance that you would provide?
Yeah, I think no, surgeons should not manage, because if they are manageable endoscopically, it's better than a redo surgery. So in order to avoid a failure that can be very high if you have no experience, there's nothing wrong. Also, if you are in a pancreatic, where in a center where there is a pancreatic center, when there are surgeons, but maybe there's no this kind of expertise. But I think there's no problem to send to another centers where they perform more. Because if you look at the literature, you know, there is one of the biggest one of the guy who publish the most is a German guy, Uwe Will. But for example, he has a paper with 60 patients in 12 years. That means that these are really rare patients that should be managed by centers where they have the experience. This is my belief. So that I don't think there is something wrong to say, oh, you know, this is not for me. I just give to somebody who is expert in this, and is for the good of the patient.
Alberto, do you have a preference of a stent that you choose? Is it a single pigtail, straight stent, stents with central
I'm
holes?
always tempted. I'm always tempted to place a metal stent.
You're tempted to place a metal stent. Okay.
Because
A tubular
because
type
sometimes
metal stents. You're talking
fully
about tubular
covered,
stent or you're talking about
fully
lamps?
covered, no tubular, fully covered. No,
And
I
what-
tried one time. I tried one time. I tried one time. I tried with the access,
Lamps.
but then it didn't go well, so I stopped.
The duct has to be, the landing space has to be big for our lamps, right? And for
Yes,
tubular stent, you have to use a very small caliber, fully covered stent, which can
yes.
coaxially
No,
fit into the duct and then come out
the,
into the bile duct.
the
And then you can
problem,
keep
the
exchanging.
problem, the problem I see is that these are people who will live
Yeah, live long.
a
Yes.
long time, so it's not and exchange the stents, a plastic stents every 3 months with the fear that you cannot go in again, because sometimes it happens, because when you take out the stents, the hole close up, and then you cannot go with the guide wire, and then at that point you cannot do the procedure anymore because the PD is small. So I don't know. I think there's still space for improvement.
Yeah, yeah.
we were part of a covered metal stent study for pancreatic strictures by ERCP, and I've had two cases. One was in that study, the other was outside of study, in which after removal of the covered stent, this is transpapillary, that there was it was just completely obstructed upstream of the metal stent. And so one thing I worry about with metal stents in the pancreatic duct, and I would like your opinion about it, is whether this could potentially lead to fibrosis, obstruction in the
In
duct.
fact, I said that I'm always tempted. I'm not saying,
Never
I didn't
does
say.
it. He said he didn't do it.
No, I
Any
didn't.
covered metal stent.
Yeah,
I'm
he
always
said he's tempted.
tempted.
Yes. Okay. Thank you. Thanks for clarifying that.
No,
And the
but-
one
but-
thing,
and also
the
you
one
might
problem,
block off side branches, and I've heard case reports with fully covered in the pancreas duct, and then the patient had humongous abscesses throughout, like
Yes.
blew out the PD and had abscesses throughout the body.
I have placed a guide wire through what we call here in the US the Cunningham technique, or a technique to advance the guide wire through the stent, and then place a snare over the wire to grab the stent for removal, so that it allows for maintaining access to
Yeah.
the duct. But to me, the initial procedure is very stressful and difficult, but the subsequent procedure isn't always so simple either. If you have
No.
trouble with the regaining the access to the duct, how long do you leave the stents in? Is it for about a year? That's about what we do for stent
Very good
exchange.
question. Mm,
Yeah. Okay, I leave it lifelong unless the patient has pain or some symptom. Then we pull it back and then try to do exchange
Yeah.
with the Cunningham technique.
Oh, I see.
Yeah, do you exchange them every 3 months?
I
No,
exchange them
no.
Because I don't
routinely.
either.
No, no.
If they're
It's
if
so
they're not
difficult
getting
to do it.
admitted,
Yeah.
I just leave it.
So you'll leave a 7 French, 10
Yeah, but
French?
Yeah.
Yeah.
it's
Well,
gonna
then-
clot.
No, but well, if they don't have any problems for the year, then I'll
So,
pull it then.
the stent does not always drain through the lumen of the stent. It also drains beside the
That's
stent,
right.
even if it's blocked. So that wick effect keeps helping decompressing the duct and the symptoms go away.
I have one patient from 2006 that we did a pink bulbostomy on, and I did this technique of every 3 months, stent exchange for 1 year, left it out, and 4 years later, that track was mature. Why? Because I had to go in and put another stent in. But I leave them out after a year. I think it reduces the chance of stent-associated stricture. And in my limited experience over many years, there's been limited experience though, is that the patency remains intact. As long as you keep the stents in for a long enough period of
Yeah.
time. But this idea of PRN exchanges seems attractive too.
Yeah.
For sure,
just-
Sandeep has much more experience than me. Eh?
No, no.
Yeah.
So I just wanted to share our experience. We are kind of
No.
compiling our data and writing up a paper of 104 patients over 10 years. And
You see, you have
our-
a very, very big experience. I'm
Uh,
very far away from you.
no, no, physically
I'm a
away,
baby.
but so our success rate has gone up recently, and 6 French cystotome is crucial for these
Yes.
kind of procedures. You preserve the pancreas, you reserve the parenchymal hormones also which are getting, so the diabetes rates comes down, the pain comes down, and you don't remove the pancreas if you ask surgeons to do. Even a tiny hole makes
Yes.
that drains out well.
Yeah, this is true. Also perforation.
Alberto, thank you so much for joining
Thank
us.
you.
Excellent discussion.
Bye-bye.
Bye.
Ciao.
Ciao.
Thank you. So we had part of discussion, which was in the next session over here, and may I invite the speaker for the debate of surgical versus endoscopic therapy for obstructive chronic pancreatitis. May I invite Professor Marco Del Chiaro. He's a professor of surgery and he's director of HPB Biliary program at this very university. Thank you, Marco. Over to
Thank you very much for the kind invitation. Actually, with Raj, this is a weekly discussion about this patient. I think this is more than a debate, is the way we ended together. However, Raj, I consider always a friend of mine. I'm not sure that speaking about surgery in front of all endoscopies has been really a present that you gave me. But I will try to be as much as I can a good fighter for advocating surgery. But there are many question marks on that. This is my conflict of interest. So first of all, I think the first mistake everyone make regarding chronic pancreatitis, or if you want, maybe it's not a mistake, but it's not completely accurate, is saying chronic pancreatitis is a benign disease. Well, it is in the sense that it's not cancer, but if you look the survival of patients with chronic pancreatitis over time, that's actually pretty similar to some of the cancer we treat every day. So chronic pancreatitis lead to death in a significant amount of people in a relatively short interval of time, and not because cancer development, well, that can happen as well, but mostly because those patients actually become dependent by narcotics. They can die in car accident, overdose, or other reasons. So when surgery is indicated in chronic pancreatitis and why? If you look guidelines, more or less, everyone agree on one thing. The indication is pain control. And so is surgery and are surgery and endoscopy equivalent, or there is something that is better? Funny thing is that all the data we have in prospective randomized trial come from endoscopists. This is probably the first paper published in Endoscopy in 2003, comparing endoscopy versus surgery in obstructive chronic pancreatitis and showing superiority of surgery compared to endoscopy in controlling pain. Lately, in New England Journal of Medicine, the Dutch did a prospective randomized trial, again, as a primary endpoint, comparing the pain control in patients when they were in chronic pancreatitis. No big number, 19 versus 20. However, prospective randomized New England Journal of Medicine, and you can see here the surgery given advantage in pain control, in technical success, number of procedure, obviously, and the physical and health component in terms of quality of life. Later, the same group published in Gastroenterology, this is 2011, let's say, an expansion of this study. And again, even this study shows superiority. First of all, of course, the majority of patients underwent surgery didn't require multiple procedures, but also they had better control of pain. When you put together data from literature that has been done by Cochrane Group, you can see that basically the data are in favor of surgery versus endoscopy for pain control in chronic pancreatitis. Now, other big question in chronic pancreatitis is when surgery eventually should be done. And again, the guidelines are in agreement normally that as sooner you do surgery, better is the outcome in terms of pain control. And why? Because every one of us knows that pain in chronic pancreatitis is a local process, then it becomes central. And when you get central pain, whatever you do, you will probably not treat anymore your patient. So if surgery is needed, probably surgery should be done early. But are we sure about that? Do we have data supporting that? Well, I have to say that, again, the Dutch, as normally are doing lately, I mean, they did another prospective randomized trial, and they showed that basically if you start with surgery, so if you do early surgery, the pain control normally is better if in compared to when you start with endoscopy and then eventually you shift to surgery if endoscopy is not enough to control the pain. And I think even doing better than what was expected, so being shorter than 7 minutes of my discussion, I really come to the conclusion. The conclusion, beside what I told now, are a little bit different. I think surgery is definitely the valid treatment for chronic pancreatitis if the indications are correct. When surgery is indicated, I think that seems to be superior to endoscopy in terms of pain control. I think, however, that some of the studies I show here today, probably include technique and methodology that would be different from what every one of you probably does in the daily practice. Things are evolving over time. And of course, 10 years of interval time means a lot of changes in technique. So I think it's very unfair to compare what has been published in 2011, what is done in 2024. In my personal view, and this is, I think, is a little bit what we do at the University of Colorado, that, is also one of the NPF Center of Excellence for Pancreatitis, and we try to work together on that, is using endoscopy for sure as a test for potential success in surgery. I think if really the pain comes from obstruction, if a stent works, you have good success to work surgery. Otherwise, probably is not. So I think at least that's one of the big role of endoscopy. However, I think when surgery is indicated, probably doing early, but that's true for everything. I think in chronic pancreatitis is more advantageous than just wait, long. And saying that, I gave the podium to my friend and colleague Raj for listening the other side.
Thank you, Marco.
Thank you, Marco. So may I invite my co-moderator and the speaker for the endoscopic aspect of this topic. Raj, as we all know, is a good friend of ours and the host of the whole program. Raj, over to you.
Thank you, Sandeep. Marco, thank you. It was an excellent talk. And in about 8 minutes, maybe, these are my financial disclosures with a few companies related to ERCP. So what are the considerations? And I think that Marco did a nice, amazing job actually summarizing some of the key articles that I also include in my talk. But when we consider the patient, we're thinking, how motivated is the patient to minimize opioids or avoid them? We all see patients that perhaps later in their disease state, they are very used to their opioids, and sometimes it's hard to really wean them off of them. And are they motivated to do so as well? So in managing that pain. The way I approach it is based on whether the pancreatic duct is dilated. If it's yes, then ERCP will be considered, and the appropriate patient will also perform endoscopic ultrasound to exclude pancreatic neoplasia. If the duct is not dilated and they have typical pancreas type pain, then we consider other options that don't include endoscopic therapy, a non-encapsulated enzyme trial if they're specifically having pain that's related to eating. And we'll try that just for 2 weeks. Don't do more than that. I see so many patients that are still on enzymes. They think that it's going to protect them from pancreatitis. It's going to protect their pancreas health. And that's absolutely unnecessary. They're very expensive enzymes. I would encourage you to get patients off of them rather than on them for the most part. Anti-inflammatory medicines and acetaminophen can be very helpful. Antioxidants may be helpful. I usually advise that. Neuromodulators and ciliary block. But we're talking about obstructive chronic pancreatitis in today's debate. And in my introductory slide, I said it was the great debate. And it's an election year. And it may be the only debate we see this year. So we'll see how this goes. But the complex part of chronic pancreatitis is the source of pain. As Marco had shown, there's so many different aspects of pain with chronic pancreatitis. There's the ductal hypertension, there's parenchymal increased pressure, there's neuropathic pain, inflammation on the neural level that might require other mechanisms. So even if they have obstruction of the pancreatic duct, their pain may not be just that. And sometimes it's not even pancreatic pain. And so taking a careful history can be helpful as well. So in this study that Marco also had shown, yes, there were some benefits with surgery when it came to pain relief and also number of interventions. And as Marco mentioned, that the older techniques for stenting were employed in these studies. It was a small study, only about 40 patients. And only 50% in the ERCP group actually had resolution of their stricture. So I didn't find it to be a really fair comparison of endoscopic therapy to surgery. At 6 years of follow-up, nearly half of the ERCP patients had surgery, which makes you think endoscopic therapy failed in those patients. But what we don't know is whether those patients who underwent surgery in the endoscopic group actually got better. So patients prefer minimally invasive interventions. If they're obstructing stones, we consider lithotripsy, and we're currently involved in a multi-center prospective randomized controlled trial of pancreatoscopy and laser versus ESWL to manage pancreatic duct stones, obstructive chronic pancreatitis. We now have about 8 and planning to get 10 sites around the country. We're about 50% enrolled at this point. Obstructing strictures with upstream dilatation at least 5 millimeters, we consider therapeutic stenting. And these are some of the ESG guidelines from a few years ago. They recommend a 10 French stent uninterrupted for 1 year. My practice has been we do stent upsizing, sometimes multiple stents to resolve a stricture before leaving them stent free. We don't consider fully covered metal stents any longer in the pancreatic duct. I avoid it at all costs at this point. ERCP and SWAL we talk about for obstructing pancreatic duct stones. So this is a case example of a 65-year-old insulin-requiring diabetic with obstructing pancreatic duct stones, constant epigastric pain, worse at night, radiating to the back, very good indications for approach for some therapy. Already on a high amount of opioids and some acetaminophen. And so I'll see if this video will play. Oh. Well, there's a bunch of stones there in the body and the head. So this is the index pancreatogram. This is severe chronic pancreatitis. Barely can get a wire more than 5 centimeters into the pancreatic duct. And so we do intraductal lithotripsy with EHL. I prefer laser, but in this case we used EHL. And you see clearance of the duct on this pancreatogram here. This is how it looks. I mean, we cleared the duct of stones, but despite all these ERCP interventions and clearance of the duct, ongoing pain, weight loss, inpatient pain management, even ketamine infusion drips, but better PO intake, less postprandial pain. So there's some improvement in pain, but the quality of life is not necessarily where it needs to be. It's not back to work. And the ESCAPE trial, these 30 Dutch hospitals over 5 years found 90 patients, 65 patients were analyzed per protocol. That's a lot of time, a lot of hospitals, only 65 patients. So it's hard to recruit patients for these types of studies. And that remains one of the limitations when we're interpreting the data as well. During the 18-month follow-up, at the end of 18 months, there was similar complete or partial pain relief. There actually was no difference. But when they looked at it kind of monthly basis over the 18 months, the pain improvement and the Zbicki scores were better with surgery. But the end of 18 months, it was pretty similar actually. And of course, surgery had fewer interventions, and morbidity, mortality, and quality of life was similar between the groups. And I think that's a really important emphasis that we're just starting in the endoscopic literature to look at a little bit more, is what are the quality of life parameters that are improving, especially in this difficult to manage patients. And then in the group that received endoscopic therapy, only 62% of the patients had stone clearance. So that would not be optimal. In our pancreatoscopy data, we exceed 85, 90% of patients that get stone clearance. So maybe those patients would do better if adequate endoscopic therapy was performed. The one thing I would say with regarding surgery, we have these patients that have these fullness in the pancreas, pancreatic head fullness, that have upstream dilated ducts. Impossible to manage those strictures adequately to get them resolved. If there's an inflammatory mass, suspicion for malignancy, then surgical resection might be the best approach. And these pain scores, yes, they were a little improved with early surgery compared to endoscopy, but the chronic opioid use was similar between the groups, but we don't know what their opioids were from baseline. That wasn't reported. So we don't know, did it go up? Did the opioids go up in usage, and that's why their pain scores improved? We don't know that. I looked at the paper just last week again and didn't see that. And subgroup analysis showed that in the endoscopy first group, patients with endoscopic duct clearance had a Zbicki score of about 40 compared with 60 in patients without endoscopic duct clearance. To me, I think you just got to clear the duct. And methods with SWAL or pancreatoscopy, our preference is pancreatoscopy here to clear the duct. No difference in cost in this study. So endoscopic therapy is less invasive, so why not do endoscopy first? And Marco would be agreeable to that. And lastly, or a few more slides, is that early surgery may reduce the risk of developing EPI, exocrine pancreas insufficiency. Well, if they need to be on pancreatic enzymes, there are many things that are worse than that. Like that, is that really clinically significant? In my opinion, I'm not so sure. To me, it's insulin requiring diabetes. Like that's the big problem. And surgery has not been shown to necessarily improve that. And we could talk about pancreatectomy and islet cell transplant in the discussion section. In our experience, if stenting decompression does not help pain, then decompressive surgery will also not help. And often these patients with intractable pain, the pain is neuropathic, and so decompression may not be helpful. Surgical intervention series, there is significant morbidity. Our morbidity with ERCP can be pain flare-up. They're in the hospital for a day or two, pancreatitis flare-up, and sometimes the surgical morbidity can be significant. Also, I want to highlight the fact that with Pusteaux, if the stones are obstructing in the head and the patient undergoes a Pusteaux, those stones in the head of the pancreas, they remain. They really don't dissect down to the head to remove those stones. So if there's an inflammatory component to the pain, decompression is part of it, but the pancreatic duct stones in the head will remain, and that may still lead to ongoing pain. So surgery has higher morbidity, longer recovery, doesn't alter need for insulin, may have up to 50% recurrence of pain at 5 years. Patients prefer minimally invasive interventions. We do resect suspected neoplasia and pancreatic fullness. If a stent doesn't help pain in patients with dilated pancreatic duct, then maybe the pain isn't pancreatic, or it's neuropathic pain and surgery decompression may not help either. So doing surgery for intractable pain, it would likely result in excessive and ineffective surgery. I just want to end with this video. We're doing some over the last 5-6 years. I'll see if it plays or if you could play it for us. This is a patient with a stricture that was out toward the tail, has some dilation above it. That would require a tail resection if we think the pain is related to it. We've started over the last 5-6 years. We have some publication data on this where we're using laser. It's a thulium laser. In this case, it's actually in this video, it was holmium laser. But the idea is to perform stricturoplasty, the same that we would do at a hepatocojejunal anastomosis or a pancreaticojejunal anastomosis. We're utilizing laser to gently and soft strokes, usually in 3 quadrants, to open up the stricture. And we'll follow this laser stricturoplasty, which we also do in the biliary tree as well, with balloon dilation for improvement of improving these strictures. This is early data. It's felt to be perhaps organ preservation, which was an emphasis of our course last year, and then followed by balloon dilation here in a moment. You can see some improvement in the stricture just endoscopically under pancreatoscopy, and then subsequently balloon dilation and improvement in the pancreatogram. We've published our series of about 35 patients just about a couple years ago, showing improvement in pain scores. But really, we need other centers to consider this technique and these interventions before we can really think that we can see that improvement in the pancreatic ducts. That was just immediate, or actually on follow-up pancreatogram. Nope, sorry, immediate, and then a stent placed. So thanks so much.
Thank you, Raj. That was wonderful presentation. The last video was eye-opener actually to me.
I was going to say,
Mark, yeah, good.
it is a really good question or topic that Raj brought up. Are the symptoms related to the stones themselves, or is it the obstruction? Because in theory, if you relieve the obstruction, do you really have to get rid of all the stones?
Well, I think part of those questions are unsolved, at least by it's on.
It's on. Just bring it closer.
At least by evidence. But what actually we observed, and actually Raj told very well, and as my opinion is that independently what will be your final treatment, and I think there are many things we also didn't went through, right? If you are 40-year-old, there is a big chance if you have an obstructive pancreatitis responding to stenting that you will go to surgery one day, right? If you are 78, different story, right? But I think this is a very important question. I believe thinking the surgery comes after failure of an endoscopic treatment on obstructive pancreatitis is probably not the best answer. Because, I mean, if obstruction is the issue, endoscopy should show that you have an improvement at least. If you don't have it, problem is different. It could be central pain, could be, parenchymal, hypertension, but the reality is that I think, I don't believe it's surgery versus endoscopy. I think it's when, who, how, and it's a combination of treatment.
And I wonder with respect to the data on early surgery versus endoscopy, whether it may be also catching the patient early. They're not necessarily dependent on the opioids. And I wonder if that early is important, because if we stent them and they improve their symptoms to the point where they're not requiring pain medication, then that, to me, we have a careful discussion. I didn't mention this with the patient in clinic before any endoscopic therapy that's involving benign chronic pancreatitis, that the alternative of surgery versus not. Most prefer the endoscopic route. But I wonder if some of the early is just related to when they get into the health system and whether their pain medications are, sort of we're gone too far where we can't, get them down.
Let me invite the audience for any questions and comments before you come up. I have a commenter ask you on point. Do you feel there's risk of infection after placing an ERCP pancreatic stent? And if the patient improves and he comes back to you for surgery after initial stent, does it affect or does not affect the surgical outcome?
No, honestly, I have to say I'm probably a very lucky person because I'm working with extremely good endoscopists. But honestly, I think in a chronic pancreatitis setting, I mean, what chronic pancreatitis does locally is much more than whoever endoscopists can do, to be honest with you. So I think, we saw that. I understand your question. We saw that, for example, at the beginning, once we start to give to everyone almost in pancreas cancer neoadjuvant treatment, or you see in IPMN after some investigation, endoscopic investigation, you can see the sequels of pancreatitis, and that can make surgery more difficult. But the problem in chronic pancreatitis, you already have it. So I think it's very difficult to get worse in a chronic pancreatitis patient. So I would not be very concerned in placing stent and doing endoscopic procedure, especially in chronic pancreatitis.
You are a very good surgeon. Many surgeons actually blame the endoscopy that you messed up the pancreas and that's why the results are bad. But you are very friendly to endoscopists. Thank you.
Does it make your decompressive surgeries more difficult if the duct is decompressed versus dilated? So
Yes.
That's one question that sometimes comes up in our multidisciplinary discussions.
So I have to tell you, I was used to do in the past more derivative surgery. I'm more now keen to do resection instead than derivative surgery. I cannot sustain my vision with any evidence. But the reason why I'm doing that is the following. I think, first of all, resection, paradoxically, in my opinion, cut less bridges than many of the derivative. I make an example. If you do a Whipple or you do a distal, and let's say you're lucky enough that you don't become diabetic, right? And I think it's easier to, for example, have access to other treatment like removing the rest of the pancreas and doing autotransplantation. Whenever you open all the duct, you put bowel there, I think it becomes much more difficult. Other example, you have a stricture or you have a mass forming pancreatitis. I think Raj touched this point very well. When you have a mass forming pancreatitis, maybe the patient is about 65, you don't really know if you cannot exclude that is not a neoplasm there, right? So you do a derivative and maybe 6 months later, you get, a cancer. So, at the end, when you compare even quality of life after derivative procedure and Whipple procedure or distal pancreatectomy, all the study analyzing that didn't show a big difference. So at the end, I became more keen to do a formal resection for really who needs than a derivative. But there are many others that do differently, and I have full respect, and I did in the past, especially modified Frey has been probably the one that I did mostly, but I don't really, see big advantages. But independent of which procedure you do, if the duct is decompressed, it becomes more difficult, yes.
Thank you, Marco. You know,
Yeah.
it's really a privilege to work here because of surgeons like Marco who had just bring such an expertise to our pancreas program, and the fact that we can rely on our surgical colleagues for providing support for our patients, I think it's invaluable. So it's something that does require multidisciplinary management for these complex patients, because even in the best of hands, we still have situations and cases where outcomes are suboptimal. But if they're at a high volume center with multidisciplinary care, then we feel like we're doing the best that we can for the patient. So thank you, Marco. Any
Thank you, Raj.
questions?
One question to Dr. Raj. So, the use of the laser in the pancreatic duct was a real fascination. I wanted to know, like, what are the practical complications you come across when you use laser? Because in India, we have a dilated duct with a lot of calculi. And I mean, we try to do laser and all, it can land up having sometimes pancreatitis also.
So I think that I first started doing this because I had a patient that had a fragmented pancreatic duct stent, and it had embedded in the pancreatic body with multiple stones around it. And so I couldn't, the option was really surgical resection, or maybe a Pusto, but when I did the pancreatoscopy, I was treating stones, and I found that even getting through the stones, I couldn't find the area of where the stent was located, the fragment, even though I could see fluoroscopically. And then it really was our laser technician who said that, well, you know, the urology folks, they will ablate bladder tumors. I go, oh, okay. So she dialed the settings on the homia from stone setting to soft tissue. And then that's actually when we started doing laser stricturoplasty. So did ablation, dissection of the fibrosis, was able to retrieve the stent, fortunately. I think the concerns about pancreatitis are similar to doing pancreatic endotherapy for other indications as well. And I think early in your experience, if you leave a 018 wire or 021 wire across the stricture, it might be best, and then do the laser side by side, because there is a risk of ductal leak. And if ductal leak occurs, you have to stent it. If you don't stent it, that's a big problem. It's manageable, but it's a big problem if you can't stent. But in general, what I tell patients is that's one of the potential risks. As you get more experience in how much to cut and so forth, it becomes less of an issue. And I don't use a protective guide wire. But yeah, I mean, I don't quote anything differently, and I haven't seen any different rates of pancreatitis following this intervention, because they're already chronic pancreatitis. And so same thing for the biliary tree. We're going to be stenting across it every time.
Can I ask you a question, Raj, about that? How, this I think is also an interesting discussion for everyone. How could you be sure that when you have a stricture is not a malignant stricture arising in a context of chronic pancreatitis or whatever it is? Or sometimes you know that chronic pancreatitis and main data PMA, actually you publish on that. They can be there together. So, I mean, how can people be sure they're not, you know, treating with laser something that maybe should require something else?
That's an excellent point. So I should emphasize that these are, and this was not the basis of our talk, so I didn't get into too much detail about it, but these are patients who have recalcitrant pancreatic duct strictures. So they may have been seen on index pancreatography. They almost always, especially in the appropriate age group, will have had endoscopic ultrasound to help exclude neoplasia. That stricture on that pancreatoscopy, very benign features, was concentric, smooth. But if there's any, you know, mucosal changes or mass-like changes, vascular changes, tumor vessel type things, we do biopsies and be sure that we're not, you know, dealing with a malignancy. But these are folks that have failed stenting or were unable to even get a stent across the stricture. They become so fibrotic, and those are the times that we utilize it.
Oh, no.
So,
I was just gonna ask, Raj, do you have to do these procedures repeatedly? So you bring them back and laser them multiple times?
For the pancreatic duct, most of the time it's just once.
And then a
But there
stent?
have been a couple, and then a stent and upsizing of the stent, and then I have them stent free after the following ERCP. I have a couple of patients in which I've done it twice, but it hasn't worked. So I think that if it doesn't improve things after one laser treatment, it's probably not going to help. And also, what I've learned in the last 6, 7 years is that too much cautery is a problem. And I don't mean that you get bad pancreatitis, not like that, but too much cautery can maybe lead to more fibrotic changes. In some cases, in one case I recall, the stricture actually got worse, not better. So this is anecdotal, small case series, but I would just be cautious about I think a less is more when it comes to utilizing laser in the pancreatic duct.
And just to extend on that, do you do full circumference laser or just 3/4 of it? Half or 3/4?
Sometimes it's hard to position the laser exactly where you want to, so it's a combination of duodenoscope repositioning, the pancreatoscope as well. If you can get 3 quadrants, two quadrants I think are minimum, and then 3 quadrants would be ideal, and that's what we reported as our technique when we published our experience.
Thank you. And you just gave us an idea that we have some of the patients who have these stents embedded in the pancreatic duct with stones forming around it, and we have no way to remove it. I think this is a good idea. I'll probably go back and try those patients now. Question from the audience, please.
Yeah, my question was, despite counseling, if someone has continued insult or injury to the
Can
pancreas.
you come closer to the mic?
Sorry, despite counseling, if someone has continued insult or injury to the pancreas with tobacco or alcohol, and they also have obstructive pathology, is this someone that you would change your approach to endoscopic therapy or what you would offer? And then even from like a referral standpoint, is this someone you would refer to a tertiary care center for endoscopic options?
Sure. So me personally, with my patients who have chronic pancreatitis in my region of Pennsylvania, it's a large smoking population, large drinking population. And so there is extensive counseling that goes on. But, you know, it's kind of like going to your neurologist and complaining of headaches because you're banging yourself with a hammer in your head every day. So I try to explain to the patients, you know, you're not doing yourselves any favor. And honestly, I worry about them. You know, when in our institution, we do have pancreaticobiliary surgery, our ability to do total pancreatectomy is not there. So my surgeons at our institution will traditionally do either a distal pancreatectomy or a Whipple procedure. And if the patient needs a formal total pancreatectomy, they're getting referred to a university setting at something at like the University of Pennsylvania with transplant, islet cell transplantation harvesting through Minnesota. So it's a big deal. It's a big deal in terms of access to care in my region. So I explained to patients that, you know, we can try endoscopic therapy as best we can, but you're not doing yourselves any favor. So I really try to maximize medical therapy and counseling for these patients. I give them nicotine counseling. We have alcohol counseling that we do in our clinic as well. And I try to get the patients to as best that they can to stop their substance abuse. We also have a VA right across the street from our hospital, and these patients also tend to be big drinkers, big smokers. So it is a very difficult situation. I do offer endotherapy in terms of ductal dilation. If there's duct dilation and endotherapy with stenting to see if there's any ductal hypertension that would be amenable to possible surgical resection. But if they're not responding to that, I try to maximize medical therapy, and I don't necessarily put them through surgical referrals at this time because I feel like it will be something that may not necessarily be fruitful for them.
Does it answer your question? Thank you. One more? May I also request the audience to ask questions about the lectures that were in the morning, both to Uzma and Josh as well, regarding that aspect, please.
Hi, thank you, everyone. So in regards to patients who don't have a stricture or obstructing stone and there's no role for endotherapy, and you presume or assume that the pain is central or neuropathic, is there any utility for EUS guided celiac block?
In my practice, at least, I don't perform it in benign indications like chronic pancreatitis because usually the pain is multifactorial, and if there is even a day of improvement forever, I now own this patient every time they come to the hospital, and they'll call me to do another a block. So, you know, the response, if any, is transient, and the data shows the results are variable. So I don't routinely offer this, and I think a lot of big centers have moved away from doing it. Raj, I don't know if you guys.
I have a different approach to it. I think that the and I agree completely with Usma. It's like 55% or something improvement. But then we looked at our data on splenectomy, surgical splenectomy with our thoracic surgeons, and had a poster presentation at a meeting a few years back. And that was about 55, 60% benefit as well. And so I think that if they're non-dilated pancreatic ducts, I do try to optimize some of these medication trials, neuromodulators initially, or I have an anecdotal bias that maybe neuromodulators on top of a block, to help sort of synergistically. That's not data based. So I offer celiac plexus block in the scenarios where, and I think many of our folks in our group will offer it, but we look at it, we don't keep repeating it if it's not helping. So if they get a clear benefit, and I don't mean for a few days or a week. It's interesting. The reason I started doing more of it, or I shouldn't say more of it, the reason I kept doing it when some of my colleagues around the country were not offering it is because you look at the pain service folks, and they will literally schedule these folks for percutaneous celiac plexus block every 4 weeks. They just keep going in for it. And I thought, oh my gosh, some of them may not even have a clear diagnosis of chronic pancreatitis. And I found it to be more invasive. We can see the celiac axis better. So in many ways, we do it under deep sedation and can provide a service for patients. So if they have sustained improvement, that's usually what we put in our report. Sustained report response minimum 6 weeks, then we'll offer a repeat. But we tell them very carefully, and before we do even one block, that over time, over 1 year, 2 years, 3 years, 4 years, Dr. Springer and I, Dr. Springer's in the audience, and I had a patient that mutually shared that every 9 months, every year should come back for a block. And I'm like, this has got to be placebo. It's burnout. But for a good 5, 6 years, once a year, every 9 months, we would have her come back, and she did great with them. No opioids during the time that she had received the block. So, you know, case series, personal experience, but that's been my practice.
Sorry. I'll echo. I echo Raj. Maybe I'm biased because I was trained here, but I similarly offer celiac plexus blocks for our patients because your alternatives for these patients who are not necessarily surgical candidates or are opioid dependent and really don't want a surgery. You really are trying to exercise everything that you can do. And so if they do have a response, even though the response isn't great, I'm a little bit longer. I'd like to see a response around 3 months. So if they're at least robust for at least 3 months and they're doing well with that and they can tear down on their opioid use, I will offer it again. But the patients that they keep coming back, if they're looking at you every 4 weeks for one, that's not necessarily the best issue. And there is a small risk of causing retroperitoneal abscess. And I did have one patient on her 4th block develop a retroperitoneal abscess from a celiac plexus block over the course of 3 years of management. And that was kind of the nidus to say, you need a total pancreatectomy. We can't do this for you anymore. And she's doing better now after surgery, but that is something to consider, that it's not without risk and you can hurt these patients with these procedures.
Raj, what do you use for celiac plexus block?
We use the bupivacaine, I think it's 0.25%, 20 cc's of that, and then a total of 80 milligrams of triamcinolone. But they come in, that's a 40 milligram per cc, so we dilute it. We actually, in one 10 cc syringe, will mix the 10 cc's of bupivacaine with 1 cc of the triamcinolone. It's a 10 cc syringe, but you can get that extra one in, and then we put a little extender on the needle because it is very difficult to push. And so we get a little IV tubing to extend it, and it reduces the amount of resistance that the nurse or technician needs to push with to get the medication in there. And usually I use a 22 gauge FNA needle.
And you mix them two together, not separately.
Right. And if you mix them in advance, they can settle a little bit or separate. So they usually will kind of move the syringe around a little bit to shake it up a little bit and then do the injection.
So I have a different way of injecting for celiac block is I inject the anesthetic agent first, then follow with this triamcinolone, and then a third injection back with the anesthetic agent. So it's a sandwich technique because mixing sometimes causes problem, and you don't know if it's not working because of the two things got interacted in the syringe itself. I also sometimes use alcohol in patients with chronic pancreatitis if it's not going to be a surgical candidate or they had surgery in the past, where it also helps. The ganglion injection is sometimes difficult in chronic pancreatitis. It's more easily seen in patients who have cancer. but we have to be liberal. If you find a ganglion, target that. If not, at least spray it all around so that it diffuses well.
Do I am allowed to
Please.
introduce another topic, and I'm asking a question regarding cystic lesion? So I want to first declare my potential conflict of interest. I've been the PI of the European evidence-based guideline published in 2018 in GATT, and actually I'm now, together with other people, organize a global guideline that hopefully will put together more than 20 societies in having a single document. There are two things in your lecture that I would like to have your comment, because I have a little bit different ideas on. One is main dot. I think you told very, very clearly, I try now here to make simple. Branch dot almost never go to cancer, or very few. Main dot basically is a pre-cancer real lesion. There are several studies, and actually in the European guideline is defined one of the relative indication for surgery, that already from 5 to 10 millimeter dot dilatation, the risk of cancer is significant. That's very much in resected series, but even in follow-up series, the risk of cancer increases. So what do you do when you have a dot between 5 and 10? Normally here we are pretty aggressive, especially if we have proof that this is really a main dot IPMN. The second question that's going the opposite direction, you mentioned MCN and you told, well, this is when you're sure go to surgery. Actually, European guideline has been the first one say you can wait until 4 centimeter if there are no really concerning radiological feature. And actually now they start to have a significant retrospective, a large series demonstrating that actually if you don't have any concerning radiological feature, basically you almost never have malignancy below 4 centimeter in diameter for MCN. So our attitude now is normally don't go, or at least offering surveillance for MCN below 4 centimeter without any clinical or radiological concerning feature.
Well, so to your first point with the duct diameter, I just mentioned the 10 millimeters as a clue that it is main duct, because usually chronic pancreatitis, even you don't see it that big, but not necessarily saying that that's not, it can't be main duct at a lower diameter. I think the hard part is just discerning what it is, and often it is between chronic pancreatitis and main duct IPMN, but if we think it is main duct IPM at any duct diameter size, we would say send them to the surgeon.
Yeah.
And then for the MCNs, okay, this is new information. I think at our center, the question is always confirming the diagnosis. And I'm trying to think now if maybe the ones we've diagnosed happen to be the bigger ones, because if we confirm it, they have all gone to surgery. And again, it's in the tail. So a distal pancreatectomy in a 50-year-old woman, they're going to probably go to surgery. But that'll be a change in our approach maybe.
Well, I think there are at least two multi-center retrospective study with some hundreds of patients showing more or less this data, and that's why now in the guideline is an option. I'm not saying that going to surgery is wrong, because there is a very good chance lifelong. You mentioned correctly, you're maybe 35, so it's very probable that you have a chance to progress. But I think it's reasonably safe with the data we have. I mean, suggesting, I believe personally, MCN we believe was more, dangerous than IPMN. Probably are very similar in terms of risk, progression. I think we have less information on MCN though.
I think the hard part is just, again, confirming the diagnosis,
I agree.
right? So a lot of times, again, a young woman, tail lesion, might go to surgery just so we actually know what it is. And sometimes it's even a serous cystadenoma that
I
was,
do agree. Oligocystic.
yeah, those look like everything. So that's the hard part.
Yeah, we have a comment.
So Dr.
question.
Siddiqui, on that topic, when you're trying to make a diagnosis of main duct IPMN, in the absence of pathognomonic signs, like what is your approach? Do you sample the duct within?
Why do I think it's main duct IPMN then? Dilated duct, recurrent mild pancreatitis. I mean, so there's usually going to be some clue that makes me think that.
So if it's a dilated duct in the absence of chronic pancreatitis, do you do an FNA to sample the fluid from the duct? Do you?
Every now and then I have done that, where we have tried to aspirate fluid, or if we see any nodularity or growths within the main duct. Obviously there's a risk for pancreatitis, but those ducts you presume are obstructed already from mucin, or if there is a soft tissue growth in there, so we might target a sample there. We
Can I-
don't do pancreatoscopy
Sorry.
as often, but sometimes we are asked to do that to try to get a direct view of the epithelium of the pancreatic duct.
So if I can add a couple of things. Number one, I think be careful. You can have a clear chronic pancreatitis picture that has been caused by a IPMN. So you can have both together. So wherever you see calcification, is not that that's exclude IPMN. In contrast, that's actually a big risk factor to miss an IPMN. I think puncturing the duct is not what is our practice, and I would like to have a comment from Raj. I think pancreatoscopy for us is more where we go for. But if you visualize papilla and you see mucus coming out, as she showed this, that's it, right? Also, radiology can help. Normally, in the typical chronic pancreatitis, you have a sort of digitiform, maybe dilatation of the branch duct of the main duct. In IPMN, in a few, you have the typical mixed type aspect where you see the cyst together with the main duct dilatation. So I believe there are some radiological findings, but I think, especially for small ducts, I think can be more difficult, and where pancreatoscopy sometimes can be very useful, in my personal view.
We published our series of pancreatoscopy in patients with chronic calcific pancreatitis that had no clear etiology. And we did this with Isaac Reitman in Houston and our center. And we only reported on about 21 cases, and some of them were symptomatic, some were not, but they had dilated PDs, and we were finding main duct IPMN within them. So we do have a low threshold for pancreatoscopy in the appropriate patient to exclude main duct IPMN. And mucin is a thick fluid, as you know, and it can be a risk factor for proteinaceous debris and stasis and stone formation. So they're not mutually exclusive. You can have chronic calcific pancreatitis and IPMN. Occasionally in the dilated duct, and it's really, really occasionally that I might put a 25 gauge needle into it. If I see mucin versus debris, and that's a post-Whipple patient, it comes to mind because I couldn't find her PJ, the pancreagenostomy. But otherwise, we try to avoid transductal aspirate because of the risk of PD leak that Dr. Siddiqui mentioned.
I was gonna say, so usually we'll do the EUS first. That always is done. And I'm looking to see, is there obvious mucin in the duct, or sometimes you'll find some soft tissue growths that you can see. And in those cases, and again, I should clarify, it's not done that often. We'll try to sample those. But then if the EUS is unhelpful, then pancreatoscopy would be our last step.
May I ask you, do you use pancreatoscopy in a patient of IPMN mainly for diagnostic purpose or also for the mapping? You want to know the length of the stricture or disease involvement, and that will help your surgeon.
You may saw in my conflict of interest actually one of the co-PI of the Boston Scientific prospective observational study on intraoperative pancreatoscopy, and I published before. Actually, I think it was published a few months ago. My previous experience when I was working in Sweden. So I like in mapping. So diagnostically, if you need diagnostically, obviously you do preoperatively. That can give you an help even for the extension of the resection if all the data is involved. But if it's not, I think intraoperatively has a much higher accuracy, because what do you do? Just practical. You cut the pancreas, you put the pancreatoscope, and you see whenever, well, we need to validate that that's correspond to the truth. That's the issue, right? But let's say you see IPMN, and for us, our discovery has been that when you see neovascularization, that's correspond to aggregate dysplasia normally, much more than when you see papilla. So can be tricky to understand where it finished. But actually, whenever we see the duct become normal, you can take it out your scope, you put over the pancreas, and you cut there. So you exactly can personalize the length of the resection. And I think, we do here with our colleague GI. So I think in the future could be that surgeon can also maybe do it. Technically, I think it's pretty easy. But the reason why we do together is because our GI colleagues definitely are exposed much more than us. And they have, I think, better eyes, if you allowed me to use this terminology. I think they're more experienced. So we use their experience in the OR to help us to avoid the total, but not leaving even skip lesion beside eventually the place where we cut. So you cut, you send the frozen section is negative, but we know that IPMN can have skip lesion distally, and that's probably one of the reasons why you have a recurrence in about 20% of cases, even after a resection with negative margin, I mean, in the remnant. So I think, to me, is very useful. I think we need still validation to be sure that that can become the normal, the routine, let's say, in the approach, in the surgical approach of IPMN. I like it, but I don't have evidence that that's really changed the long-term outcome.
Thank you, Marco. That's very clear. Now we have some questions from the audience. I have a question to Josh. How often do you perform upfront necrosectomy? Have the results from Destin trial influenced your practice?
That's a good question. How often do I perform upfront nephrectomy? Almost never, because I've had bad outcomes with stent dislodgement. So I know the Destin trial suggested that patients may have shorter duration and quicker resolution to resolution of their necrotic collections. However, I think at initial time of limit opposing metal stent placement, if you're going in and doing a necrosectomy on the same session, I have gotten my devices caught on that stent and dislodged the stent unintentionally. And now you're dealing with a possible perforation or salvage procedure, which is not necessary that you have to put the patient through that. I mean, if it's the difference between 1 or 2 procedures, and that means certifying that they're going to safely have a necrosectomy with low risk of perforation or need for emergent surgery, I prefer that than 1 less procedure.
Thank you, Josh. As a conflict, I was part of an author of that paper.
Yeah.
We have a question from the audience, please.
Oh, sorry.
Yes, I also have a question for Josh, and it's also regarding the wall of necrosis. So in the Netherlands, we see that more and more hospitals go to the from the lumen opposing stents back to the double pigtails as initial drainage, because there's not really any evidence that the hot axials or LUMS is better than the pigtails, and the cost is much higher for the lumen opposing stents. So what's your view on that?
Yes. But anyway, yes, you're 100% right. But I think in terms of what you're trading for cost, doing a double pigtail stent placement through a traditional method or doing a self-expanding metal stent with a transaxial pigtail stent at time of initial access to your collection, yes, it is possibly less costly. I think what you trade in cost, though, is time and efficiency. So in a busy practice or something where you have patients that you need to handle, having an hour and a half to do access or an hour to do access with fluoroscopic guideless through a traditional method versus taking 10 minutes to access the collection and let the stent sit is a big difference. But you're not wrong. I didn't go into the data regarding that. The outcomes in terms of using the traditional method with trans-pigtail and coaxial pigtails rather with the self-expanding metal stent versus using upfront lumen opposing metal stent, outcomes are similar, adverse events are similar, and cost is better with the traditional method. Great question.
Thank you. We have another question for Uzma. That's the last one. How do you manage your young patient with small 1 centimeter or lesser pancreatic cyst side branch incidentally discovered?
I know this patient's going to end up getting a lot of scans over their lifetime. If you go by the ACG 2018 guidelines for these tiny sub-centimeter cysts, they recommend an MRI in 2 years, but there's no mention of stopping surveillance. The AGA guidelines from 2015 didn't have any endosonographers on their panel, and they do mention stopping surveillance after 5 years if there's no change in size, but I don't think that most of us have made that kind of big jump yet. I'm sure over time, maybe with more data, we'll be brave enough to do that, but
I think.
but right now they get
Well,
ongoing.
I have to tell you,
Yeah.
you mentioned before, and that's probably the practice in American endoscopy. I don't know. I mean, there has been a paper published in gastroenterology, I think, last year, where they survey. I mean, the most used guideline, definitely the AGA were not at the top. Actually, the European were at the top. But independently by that, I think also the IAP will be combined. I mean, we are very much followed. I don't think we have evidence enough that we can stop those patients. I mean, I believe that's where we need to go, right? You mentioned million. Actually, there is a paper from Germany, prospective on healthy population. They did an MRI and they found the prevalence of cystic lesion, whatever cystic lesion, 1 millimeter at 49%. So clearly, if you think that you need to screen lifelong under 50 million of Americans, you understand that's unfeasible, right? But let's start, I think, where safe is. patient unfit for surgery. There are a lot of patients who will never go to surgery because they are older and unfit, and still we follow. That's, for example, the European guidelines say clearly, patient unfit for surgery, doesn't matter, to follow the patient. Personally, if I have a young patient with a small cyst, I still follow because on 2000, a couple of cancer will come out, and then it would be difficult to explain why you stop. But I think in the future, we will find criteria probably to stop some of those. I think it's needed.
If you're not comfortable stopping per the guideline, the other thing is to just increase the interval.
Correct, yeah.
For it. But, when you get close to 10 years, I'm more than comfortable stopping, and I've stopped some at 5, depending on where they are age-wise.
There's a question from the audience. Yes, please.
Hi. Another question about a younger patient. In the setting of familial or genetic pancreatitis, do you change your endotherapy versus surgical approach? And if surgery, then which surgery?
Who will answer that? I think.
Sorry, can you repeat if there is a familial history?
Yeah, family history, familiar or genetic proven hereditary pancreatitis. Do you approach that patient differently, especially in the younger age range? And is endotherapy still an option for part of the time, or do you go straight to surgery?
So this is actually extremely good question with not so many. So I do pancreatic surgery also at Children's Hospital here in the campus. And some of those patients are the one you're mentioning. So the one with hereditary pancreatitis. I think, yes, and I don't want to go directly in the indication. There is a very dedicated and expert team working at Children's Hospital, and are the one really making the indication more than me. I'm more just, let's say, giving my... What I think is important, though, in this kind of patient, beside the pain control and eventually with the auto transplant, also trying to get at least as less bad as possible diabetes in the long term. I think one of the really important points is the cancer risk. One of the advantages in going early is that probably the chance to have a small cancer that you don't detect is very little, which open for you the possibility to do an auto transplant. I think in adult age, in some of those mutations, especially the one associated with higher risk, I will be a little bit concerned in doing an auto transplant, because the risk is that you don't see a small cancer, you process and you spread in the liver, right? So, and also you don't have the histology to be done and being sure that there was no cancer. So I think in hereditary pancreatitis, the really difference is that, especially the one associated with high risk of cancer, if you want to do surgery, especially with auto transplant, there should be early surgery and not too late. That's my personal view.
When you look at the data, the published data from University of Minnesota, and you look at the islet cell data, though, a third of the patients will become insulin-requiring diabetic immediately. Another third become insulin-requiring diabetic at 5 years. So if they're pretty young, that is one careful conversation to have with the patients and their parents, of course. And it's a pediatric gastroenterologist that's asking the question. So I think that's another thing, that I have some patients that are in their 20s, 30s, 40s that have opted not to have pancreatectomy. When I speak to our pediatric GI colleagues, Rob Kramer and Mike Narkowitz there, they had reduced their utilization of total pancreatectomy and islet cell transplant in the hereditary pancreatitis, unless they're really symptomatic, pretty symptomatic patients, especially.
And I think the other point here is that is a matter of expectation. In my opinion, I have a huge experience. We are trying to go in this direction even here. I had experience before to move here. When you do auto isolate transplantation, the goal is not having a brittle diabetes, is not being insulin independent forever, because that's, is not achievable in many patients. So I agree with you, Raj. Especially for chronic pancreatitis, because you already have a damage there. So even your beta cells reserve is not the one of a real normal pancreas, right? So I really believe that a clear expectation discussion with the family, with the parents, and so on, is very important in those patients. And, I don't think, still we are speaking about small populations. So I think even data available are important, but are never probably enough to really give us a strong evidence of what needs to be done.
Thank you, Marco. We have two last quick questions, which I request Josh to address quickly.
Sure. So the first question we have here is, what are options and rescue strategies for misdeployed Axio stent? Don't panic. That's probably number one. But when you're doing lumen-opposing metal stent placement, initially in your practice, there is the option for having wire access to the collection through the top of the stent. So there's a small conduit where you can place a wire and coil it in the area of interest. So in areas where I'm concerned about maldeployment, not usually in walled-off necrosis or pseudocyst management, but sometimes in off-label use such as gallbladder drainage or gastroenterostomy, if I'm concerned, excuse me, about possible maldeployment or not being able to salvage the procedure, once I get access through the collection and deploy that internal flange, I will throw a rescue wire into the collection in case I need to bridge the defect for any reason. So if you do maldeploy the stent either entirely into the collection, you could try to place another Axio stent over the wire and just get the Axio stent later on another interval necrosectomy. If you cause a perforation and you can't necessarily find the area of interest that you've damaged endoscopically, that rescue wire will allow you to bridge with either a fully covered esophageal stent or a fully covered biliary stent if the collection has kind of pushed away into the retroperitoneum. I had one recently where it maldeployed and we had to find the defect into the pseudocyst, put a wire through it, and then was able to salvage that procedure with a longer, fully covered metal biliary stent and a coaxial pigtail stent. So just thinking about your backup procedures is important, and especially initial on, it might be reasonable to put a fully covered wire through, or sorry, a coiled long wire into the collection when you're initially going in with your lumen opposing stent. In terms of how many interval necrosectomies do you do before referring the patient to surgery, how long do you wait? I think it's on a case-by-case basis. As we were speaking, the average should be about 4 to 6 sessions, and so I quote patients on that. Sometimes with really large necrotic collections, I tell these patients that, you know, this can take upwards of 12 in some data series, that you can possibly require up to 12 interval necrosectomies. If I can transition a patient to outpatient management, meaning that they are no longer in the hospital, but they still have some necrotic collections with some pain symptoms, but we're handling them as an outpatient, I will continue to do that and not get surgery involved unless they are hospitalized, declining, or we are not making progress with their necrosectomies. So that one case that I highlighted after his 3rd interval necrosectomy, and I'm like, this guy's still's got a gigantic collection, I need our surgeons to assist, and they pulled out a football of dead pancreas. That was a reasonable thing to do. But I try not to get this, I keep the surgeons in the loop, but I don't necessarily get them involved in their management unless we are not making progress.
And also not too excited and intervening surgically.
Yeah.
The surgeons themselves aren't terribly, yeah.
And now it's gone to, yeah, no, you
So-
guys did a great job.
I want to thank my co-moderator, Sandeep. Excellent conversation. Marco, thank you so much. Josh, Usma, Alberto in Italy for a fantastic session. We'll conclude this morning's session. We have a 30-minute break, and then we'll see you back around that time, 10:30. Thank you.
Hi, everyone. We're going to get started so that we can stay on time. Before we start the biliary session, we thought it would be
Endohepatology.
endohepatology
Oh, no,
and
it is
biliary
biliary? Oh, yeah.
session. We thought it would be a good idea to give you a few clinical updates from our cases yesterday. So we have Dr. Pokla here to give us some updates from the cases, and then we'll get started afterwards.
Great. Good morning, everyone. So we had 5 patients that were admitted to our extended recovery unit yesterday after their procedures. The 2 suturing patients who underwent suturing for gastrogastric fistula and candy cane syndrome are doing well, but they're having some pain that's still requiring IV opiates. So they'll be spending at least another night with us in the hospital. Our post-ampulectomy patient looks great. He's having no pain and he's going to be discharging home today. Our post-minor papillotomy patient who has pancreas divisum has some mild pain this morning. A lipase is pending, but she might also go home later today if she's feeling well enough. Our last patient who was admitted underwent FNA of a pancreas cyst and was kept because of chronic neutropenia and chronic thrombocytopenia. She's also doing well today, and her cyst fluid studies came back with a CEA in the 8,000s and an amylase in the 200s, consistent with IPMN, which is what we suspected. And that's everybody.
All right, thank you. All right, it's my pleasure to introduce this session's first speaker, my friend and colleague, Dr. Jason Samarasina. He is going to be talking on endohepatology, portal pressure, biopsy, and variceal therapy. Jason's the associate chief at the Division of GI and Hepatology and director of the Interventional Endoscopy program at UC Irvine.
Thank you, Usma. It really is an honor and pleasure to be here. I'd like to thank Raj and Anna and Sachin for the kind invitation. I was here a number of years ago as a fellow, and I was just amazed at the amazing faculty and the complexity of the cases. It's really a career highlight for me to be here. So thank you. These are my disclosures. So liver disease accounts for nearly 2 million deaths worldwide annually, and metabolic dysfunction associated steatotic liver disease has become the most common cause of chronic liver disease, affecting up to 25% of individuals globally. And we're seeing a growing number of endoscopic procedures that are pertinent to liver patients, particularly surrounding endoscopic ultrasound. And so Dr. Kenneth Chang saw this happening, and he coined a term called endohepatology. And this is really the integration of endoscopy within the practice of hepatology. And my kind of subtitle to this is, it's really making the liver cool again. In this book, we talked about different things that, would be great to achieve using endoscopy, variceal management, liver biopsy, elastography, and portal pressure measurement. And so I'm going to talk about a few of these things today. So EUS-guided interventions for variceal bleeding. And a lot of the world, this is really the management of gastric varices. It's basically an endoscopic puncture of the varix and basically injection of glue. And sometimes it doesn't always go as planned. And with EUS, you can potentially have better assessment of the size, morphology of the varices than EGD. You can use Doppler to evaluate flow. It doesn't require any luminal visualization, potentially more accurate delivery of glue, but there is a disadvantage of potential systemic glue embolization. So we have adopted embolization coils from interventional radiology to really serve as a scaffold for glue to reduce the risk of glue embolization. And the coils are made of the soft platinum with synthetic fibers to promote clot formation. And they work really quite well with our EUS needles. This is the introducer of the coil, and basically attaches to the inlet of the needle. And then we use our stylet to kind of insert the coil into the needle. We remove the introducer. And then we use the stylet to push the coil further and further towards the tip. And when we're ready to deploy the coil, we just push it out. So Dr. Binmoller did one of the largest series of EUS-guided coil embolization. I'm going to show you the video from his initial publication of 152 patients. So this is the EUS image showing Doppler flow, measurement of the variceal complex. So there's a EUS puncture. And after puncture, there's a 20 millimeter coil inserted into the varix. Followed by injection of the glue. And then you can see here, there's a residual varix, so repuncture, and then placement of additional coil. And then additional injection of cyanoacrylate glue. So in this series, there was 152 patients. Most of them had recent bleeding. 5% had active hemorrhage. But once EUS confirmed obliteration, the post-treatment bleeding rate was only 3% on follow-up. Now, one of the kind of annoying things about the glue is there really isn't a commercially available system for the glue. So we end up breaking up packets and trying to get it in needles and syringes, and it doesn't really work that well. And so Marvin Yu has discovered that using absorbable gelatin sponge as an agent in place of the glue has worked extremely well. It's used routinely in surgery. It absorbs 45 times its weight of whole blood. And it's essentially an inert substance that doesn't lead to any fibrosis, tissue reaction. It's injected as a slurry. And it's fairly easy to prepare. You can just basically take these strips, cut them up into little pieces, put them into a syringe, and then essentially mix that with some saline and create a slurry. So a really, really easy preparation. And Marvin's done some great work with this absorbable gelatin sponge and really has had some great results. So in terms of EUS-guided variceal interventions, EUS, could be better to assess the size of morphology than EGD, using Doppler to evaluate flow. It doesn't require any luminal visualization. Again, the disadvantages are systemic glue embolization, but the gelatin sponge slurry may be better. And one of the issues with this procedure right now is there's no standardized training for this procedure. And when you discuss these cases with your team, you really need buy-in from interventional radiology to make sure that you're doing the right thing for the patient, because sometimes IR might be the better option. Okay, I'll move on to EUS-guided liver biopsy. We all know liver biopsy plays a pivotal role in evaluating and directing the therapeutic management of patients with liver disease. Percutaneous biopsy is one method. And a while ago, for GI fellows, we all need to learn percutaneous biopsy. Now we no longer do. Interventional radiology does most of our biopsies. But with EUS, there's potential advantages. It could be technically reproducible regardless of the body habitus. It's possibly less painful. And the image-guided approach allows us to avoid blood vessels and access a wide segment of liver parenchyma, including the left and the right lobe. Now, if you look at the minimal measurements we need to achieve by the liver societies, it's really about a 2 centimeter length and a greater than 11 complete portal tracts. And so the group at Geisinger has done a ton of work in this area. This is one of their first studies. It was a multi-center study of 110 patients. They used a straight 19-gauge needle, 7 to 10 actuations, and they actually got pretty good results, 38 millimeter lengths, median complete portal tracts of 14. So this was really kind of a pretty good start. The group at Brigham has done a lot of work in this area, and they did this study on a human cadaveric model. They used 6 different types of needles, straight needles, a new core needle, and some percutaneous needles as well. They used different techniques, 1 versus 3 fanning passes, dry needle with varying suction, and the outcomes were complete portal tracts and degree of fragmentation. So a very, very nice study looking at different needles. So essentially, there was 48 passes per needle. And the results showed that basically 3 fanning passes were better than 1. Dry suction, with dry suction, there's really no significant difference between slow pull, a 10 mil, 20, or 30 cc slow pull. And in terms of complete portal tracts, the short core needle appeared to perform better. And in terms of fragmentation, the short core needle did a better job as well. Now, getting back to the technique of dry versus wet, again, the Geisinger group did another study, 40 patients, crossover study. They had essentially 3 separate passes. The first pass was this dry pass that was just with the stylet pulled with 20 cc's of suction. The second pass was dry with heparin, so a heparin flush, then an air flush, and then 20 cc's of suction. And the third pass was basically a heparin prime needle with a 20 cc's of suction. And in this study, they showed that the wet suction technique was definitely better. So we did a study looking at 2 kind of novel F&B needles, one with the Francine tip and one with the fork tip. And this was a prospective repeated measure crossover study, 1 pass and 1 single actuation. So not very typical of what we do in clinical practice, but we wanted to do this to see, what kind of passes we could get with just what kind of results we can get with just 1 pass. 44 liver biopsies in 22 patients. And if you look at it, even with just 1 pass, 1 actuation, we actually got very good results. There was histologic adequacy in almost all specimens, but the Francine tip needle did do a better job in terms of complete portal tracts. So we just recently are about to publish a video on something we're calling the new dynamic wet suction technique. And just to kind of show you what that looks like. So this is a real simple modification to what a lot of people are probably already doing. For the first pass, we actually take off the syringe. So before we puncture the liver, the syringe comes off, we puncture, we put the syringe back on, we open the suction, and then we close the suction. So it's open, close, just about 2 seconds. Then we bring the needle back to about 2 centimeters from the liver capsule. And for the second and third pass, we open, throw, and close. And we do the same thing for the third pass. So again, bringing it back to 2 centimeters below the liver capsule. Open, throw, close. And what we found with this sort of new kind of modification is just a dramatic improvement in the specimen outcome. So 31 patients over 12 months, technical success 100%, no serious complications. But now our lengths are about 6.7 centimeters. Again, AASLD is looking for 2 centimeters. We've had specimens as long as 16 centimeters. And average complete portal tracts, we're getting about 23.8 per biopsy sample. Again, much, much higher than 11. And all the specimens were adequate for diagnosis and staging fibrosis, and 39% of our patients were actually had advanced fibrosis. So in terms of US liver biopsy, I think core versus straight, the newest core needles definitely appear to be superior to straight. Pain appears to be more common with the core needles, though. Technique matters. A single actuation may be enough, but 3 is likely better. Fanning helps. Longer excursion leads to more tissue. And right liver may be better than left because usually the excursions that we can achieve on the right side appear to be a little bit better and longer. The heparin prime needle with wet suction is definitely better than dry. And this new dynamic wet suction technique that I just described seems to be the best in our opinion. So EUS-guided liver biopsies are clearly exceeding the minimum AASLD requirements. And really, we need to start doing these correctly and getting the word out to our hepatologists. Something kind of new that I'll just touch on. We've all heard of FibroScan and vibration-controlled transient elastography, and this is one of the most commonly used procedures in hepatology, but there's definitely some limitations, especially in patients who are morbidly obese. And so EUS-guided shear wave elastography can be an alternative to FibroScan with other potential advantages. So real-time visualization allows the operator to really select an optimal spot for measurement. It can be performed in patients who are morbidly obese or who have narrow intercostal spaces, and both the right and left lobes can be assessed, as well as the spleen. And so this is a pretty easy procedure. The newest endoscopic ultrasound processors have this feature, and you basically control a bounding box to highlight the region of interest, and you basically press a button. Within about 3 seconds, you get kind of one of these measurements. We take 10 measurements, and we get the median. So we looked at this in comparing it to EUS-guided liver biopsies, and we used the same types of cutoffs that had been established previously in other studies. And essentially what we found was, if the shear wave value was greater than 15 in the left, the right, and the spleen value was greater than 26, your sensitivity, specificity, and positive predictive value was very, very high for stage 3, 4 fibrosis. So again, really interesting stuff. There really hasn't been a formalized protocol to get these measurements. And so now we're working with a multi-center group to figure out how to do this, because I think this is going to be a really interesting addition to the endohepatology workup. The last thing I'm going to touch on is EUS-guided portosystemic pressure gradient measurement. We know that the HVPG traditionally has been one of the most important measures of reflecting the degree of portal hypertension as the single best prognostic factor in liver disease. And to calculate this, it's really been interventional radiology that will basically float a balloon catheter down into the hepatic vein. They'll get a a balloon inflated wedged pressure as well as a free pressure, and that will be the gradient. The disadvantage of this is it's kind of invasive. It uses ionizing radiation, and you do get this indirect measurement of the portal vein. So that wedged hepatic venous pressure is really just an indirect assessment of what the portal venous pressure is. And in certain times with portal hypertension, that is actually not accurate. So we've had some really pioneers in this area. Bill Brugge started looking at this in pigs back in 2002. Dr. Kansavoy also tried to look at this in 2008, but it wasn't until my mentor, Dr. Chang, really kind of thought about this, and we started under his leadership putting this project together and created a novel EUS-guided portal pressure gradient measurement system using a 25 gauge needle and this compact manometer. And so this was kind of an amazing project for me, because I got to see sort of an idea kind of working in the animal lab, and then kind of just grow and kind of see it in the human phase, and then see it in the multi-center phase, and see a commercially available product. Now it's just been a kind of an amazing journey and really kind of inspirational for me. But at the beginning, it was basically us in an animal lab working with an IR resident, trying to figure out if we could do these pressure readings as well as the IR group. And so this is basically in the pig, and you can see the balloon catheter of the interventional radiology resident. And here we are with our echo endoscope with the needle into the right hepatic vein, showing basically we're measuring exactly the same place. And so when we compared the results, they were really, really tightly correlated. And so we were like, okay, I think we're probably onto something. And the system was really, really simple. So back then, and the commercially available setup is basically, very, very similar to this: 25 gauge needle, some non-compressible tubing, this compact manometer, and some heparinized saline. And so essentially you put it all together. Put the syringe on the manometer, and then connect the non-compressible tubing to the inlet of the FNA needle. And then in the beginning, we were basically having somebody hold the manometer at the mid-axillary line. And so this this pressure reading, one of the things that makes it so safe, it's a transgastric transparenchymal puncture of the hepatic vein. And it's a transgastric transparenchymal puncture of the portal vein. And so you can see here, this is a live case. So we're going transgastric transparenchymal into the middle hepatic vein here. And so we're going to get usually our fellow here to push some of the saline. You can see the bubbles here. So that confirms that we're in the vessel. And then these numbers will basically go up, and then they'll come back down, and they'll settle. And when they settle, that number will be recorded. And we'll do that 2 more times for the hepatic vein. And then we'll withdraw the needle. We'll find the portal vein, and we'll do the same thing. So this is our portal vein puncture. And again, flush. You can see the little bubbles in the portal vein. And in this case, the portal venous pressure was 26. The mean of the hepatic venous pressure was 12, and the gradient was 14. So this patient, it was, they had portal hypertension, it was elevated. So we've made a slight adjustment to the setup now. We set everything up, and as you can see, there's no fellow anymore, and we've replaced the fellow with basically a stand. And because we there was just too much drama in these cases because we would be saying, you know, like, read the number. No, you're holding it too tight. No, too loose. What are you doing? And so there was just too much shouting at fellows. So now, yep, we've got a stand. We've got a laser level that we just basically shoot at the metaxillary line. You know, we get our friends from Cook to get a piece of double-sided tape, and we literally just like put it on there, and it works even better. And that's it. So so we published the initial human series, 28 subjects, with 100% technical success in obtaining measurements and accessing the vessels. There's no complications. And basically, we were able to show that, you know, higher portal pressures wherein patients had a high clinical risk of cirrhosis. Those that had varices had a higher portal pressure, and those with portal hypertension gastropathy also had a higher portal pressure as well. And so now, since we've kind of taken this further, we've done a large multi-center kind of endohepatology experience, almost 400 patients now, just submitted to gastro, but this was our DDW presentation, and we were like thrilled that we got a Best of DDW award for this. And Mark Moniquez, our fellow at the time, presented this, and basically we were looking at the correlation between EUS-PPG and clinical markers of portal hypertension, but also a lot of the non-invasive markers of liver disease and liver histology. Because in a lot of cases, you get these sort of equivocal, discordant results, you know, from hepatologists. And then there's sort of this kind of question mark about, you know, these patients on FibroScan, you know, in this range, you know, where do they truly stand in terms of their degree of fibrosis? And so this was a multi-center retrospective study. Some of the non-invasive markers we looked at was APRI, FIB4, and MELD, and we looked at gradients greater than 5 and greater than 10 compared to all these non-invasive markers. And so this is FIB4, this is APRI, this is MELD. And so technical success was 98.7%. It was a really low adverse event rate. And again, similar to our single center, patients with thrombocytopenia had higher gradients, people with varices had higher gradients, and people with portal hypertensive gastropathy had higher gradients. There was great correlation with FIB4 and APRI, and great correlation with MELD. But one thing that was really interesting was 39 patients had concomitant PPG, FibroScan, and liver biopsy, and 19 patients had PPGs less than 5, which accurately characterized patients with 0, 1, or 2 fibrosis, but the transient elastography, the FibroScan, was falsely positive. So when you looked at the correlation between PPG and liver histology, it was really good. But when you looked at the correlation with transient elastography, it was wrong a lot of the time. The other kind of neat thing we found was there were some patients who had a high PPG, but really didn't have any other features of chronic liver disease, no varices, no PHG, no thrombocytopenia. APRI, FIB4, and MELD were low, and the FibroScans were low as well, but the PPGs were slightly elevated. And on histology, they actually did have grade 3 or 4 fibrosis. And so really PPG ended up being the best predictor of advanced fibrosis compared to all these things. So take-home points here, PPG really provides direct measurement of both hepatic and portal veins. HVPG is really not accurate in pre-sinusoidal portal hypertension. And in NASH cirrhosis, HVPG may actually underestimate the portal venous pressure. PPG in the hands of endosonographers is really more accessible and repeatable than HVPG, and maybe more accurate than some of the current non-invasive markers. And now there is a commercially available device with a short learning curve, and there are formal training courses as well. There's a endohepatology special interest group, if anyone's interested in joining. This is Dr. Chang doing his kind of live webinars and training, and he's trained over, I think, 300 endosonographers on this procedure now. So I think the value that we're adding, I think, to our hepatology community is really fantastic. Just last slide. So now, as an endoscopist, we really can provide a one-stop shop for this endoscopic liver evaluation, endoscopically looking for varices. We can do shear wave elastography. We can do these great liver biopsies now. And and then we can check the portal pressures. And I just want to comment on this this picture. So this is from the Johns Hopkins website, and it's such a beautiful image. And you know, if you told me, like, you know, like 15 years ago when we started working on this in the animal lab, that like one day I'd look at a Johns Hopkins website too and see a beautiful like picture of something that, you know, we were thinking up, you know, I'd say you're crazy. But I think once Johns Hopkins puts these, you know, these illustrations together, I think you've kind of made it. I think this is like a real thing. And so and with that, I'll end. Thanks very much.
Thanks, Jason. Our next speaker is Dr. Carlos Robles Madranda. He's the medical director and head of the gastroenterology and endoscopy division at the IECED in Ecuador. He's going to be talking to us about malignant biliary stricture imaging and intervention. Thanks, Carlos.
Good morning. Thank you again for this amazing meeting. It's my first time in Rocky Mountain. Thank you so much. I feel at home. So that's was amazing experience all these days. So thank you again. So I will talk about malignant biliary structure imaging and intervention. So this is my financial disclosures. So biliary structures occur when the bile duct narrows, which is commonly caused by the presence of cancers. Therapeutic approach to treat biliary structures depend highly on whether the structures are benign or malignant. Malignant biliary structures are associated with high morbidity and mortality, with 5-year relative survival rates for intrahepatic bile duct cancers ranging from 23% for localized stage to 3% for distant stage. Extrahepatic bile duct cancer survival rates at 5 years range from 18% for localized and 2% for distant. So imaging and intervention are key tools in managing these structures. Imaging studies play an essential role in visualization, classification, and surgical planning of various structures, and interventions offers minimally invasive solutions to relieve the obstruction and improve symptoms and maintain bile flow through stentings. We talk about imaging. This is a flow chart published in 2021. I just wanted to show you the different kind of options that we have for imaging detection and imaging diagnosis of a biliary obstruction. It means we have abdominal ultrasound, we have MRI, we have CT scan, and we have nowadays ERCP for many years ago, US, and recently cholangiography. So all these kind of technologies we can use, and mostly we use at least 90% of them to have a diagnosis sometimes. I will talk a little bit about non-invasive imagings. So we have a lot of them, you know, all of them, you know, ultrasound, abdominal ultrasound, CT cholangiography, MRI, MRCP, hepatobiliary immunodiacetic acid that showed very good results regarding what kind of structures we are looking. But the only problem with these techniques in general is that sometimes there are they don't have a lot of very good specificity. Sometimes they don't have good sensitivity. It will depend on the operator, for example, for abdominal ultrasound, and also we don't have the final diagnosis using histology. So they give us at least a roadmap. It gives us like I always use it as a GPS to determine what kind of strategy I will do with my patients. So regarding invasive imagings, we have percutaneous transhepatic cholangiography. The advantage is accurate diagnostic procedure to determine tumor extension for extra and intrahepatic structures. Tissue sample can be acquired with positive results ranging from 69 to 81%. The disadvantage requires intravenous contrast or using US in conjunction, requires more punctures if the structure is in the hepatic ileum. So you need to have radiologists, expert radiologists in this, to have the access to the biliary tract by the abdominal or percutaneous. So we have other invasive imaging as endoscopic ultrasound. We have a very good advantage. It allows high resolution image and tissue acquisition by fine needle aspiration or fine needle biopsy. FNA was found superior to ERCP with broad cytology and transpapillar biopsies with a sensitivity of 93% and versus 60% and accuracy of 94 versus 62%. However, when ERCP and US are combined, they reach a sensitivity and accuracy of more than 97%. So being better for distal bile duct structures and those more than 50 millimeters, but less than 4 centimeters. The disadvantage, FNA has low sensitivity for diagnosing malignancy, but I believe now with the FMB, we increase these results, and there is concern for potential sitting along the needle track of USFNA. So ERCP has been the gold standard technique and continues to be used not just for diagnosis. We can make diagnosis and therapeutic during the procedure. However, many things we have to tell about ERCP. The advantage for sure, cholangiogram after biliary cannulation evaluates location, anatomy, and the extension of the structure. However, with the new technologies as cholangioscopy, we know that it's not 100% of security of extension of the lesion. So it's a valuable tool for tissue acquisition through brush cytology or biopsy. When combined, they have 100% specificity for confirming malignancy, but a sensitivity of 59%. To enhance a better tissue acquisition, the use of balloon dilation alone improves sensitivity from 40% to more than 70% without increasing the complication rate. The disadvantage, risk of complications, pancreatitis and bleeding, and perforation, limited evaluation in patients with altered GI anatomy, post-surgery, or duodenal or papillary stenosis. Cholangioscopy has made a very big revolution. Now with the single operator cholangioscopy, it's more available worldwide. So we have a very good advantage, allows direct visualization and targeted biopsies of the bile ducts, has a sensitivity of 78%, a little bit more right now with the new cholangioscopes, and a specificity of 82%. Cholangioscopy guided biopsies improve diagnosis of indeterminate biliary structure when ERCP brushing and biopsies have gotten a negative result. The disadvantage is expensive. However, I believe in case of healthcare, it's not expensive, to my opinion, personal opinion. Requires an endoscopist staff, specialized training, and increase the risk of complication to 7% as cholangitis, pancreatitis, and bleeding. So this was our first publication about trying to have a classification of all the patterns that has been well described before for many experts at Dr. Shah, trying to see what were the most typical characteristic of many of these lesions. However, this classification is not perfect, for sure, have a very good sensitivity and specificity, more than 90%, but the inter-observer agreement is sometimes difficult because, you know, a lot of patterns or a lot of recognition, and we made the second publication in 2021, just focusing on neoplastic, on the vessels, on vascularity and neoplastic vessels. So the accuracy that we had was 80%, and it's easier to understand. I always say that this, when you see this kind of a spider, like a vascularity inside a lesion in the biliary tract, you have at least 80% of chance that this lesion is a cancer. So we have a sensitivity of 94%, specificity of 63%, negative predictive value of 90%, and a positive predictive value of 75%. But the most interesting was the inter-observer agreement with a kappa of more than 80%. Very good. I will talk a little bit about device aiding cholangioscopy. So we have probe-based confocal laser endomicroscopy. Yeah, it permits real-time in vivo imaging of biliary tissue at the cellular level and can be used to guide target biopsies. There is limited availability and expertise, so it's expensive, and also it's not available in all the centers. And also it's a little bit difficult to have a very good inter-observer agreement with the standard with the current classification that are Miami and Paris classification. So nowadays it's not yet available, but it's already waiting for FDA approval. So we have AI technologies on EOS, has an average time processing of 200 to 300 milliseconds per frame, and provide station recognition and bile segmentation in real time. An AI cholangioscopy offers an average image processing speed of CNN of 7 to 50 milliseconds per frame. And at the moment, the highest performance metrics gives an accuracy of 94.9% with a sensitivity of 94% and a specificity of 92.1%. This is our first publication. This was a multi-center study of artificial intelligence for diagnosis neoplasia on digital cholangioscopy, and was a participation from Europe, United States, and our center in Ecuador. So this is the AI, the first technology that we developed in 2019, 2021. You see how faster it goes, and now it's really fast. And this is the different models with different metrics that we have. So the total loss is very important, and the F1 score in this kind of technology. So it's in around 91% with a total score of nothing. It means it's very accurate for diagnosis. The most interesting of this technology and show it that AI is superior in 25% of experts for diagnosis cancer. It means 25% of us as experts, we can misdiagnose neoplastic lesion in the biliary tract, and it's 50% superior to non-experts. So probably in the future, this kind of technology will help us to get better diagnosis and, misdiagnose less cancer. So the this AI is working with any kind of a colonoscope. case that we And you performed can 2 years see ago the in green World Center live transmission in squares that online is showing all the areas source. suspected for I was malignancy with Dr. Ratislav Kuna, and you can see very well, we recognize and it's taking picture of AI that each we area developed that is for- suspected for malignancy. Recognize the pattern, the characteristic
For
of
the AI.
pattern that
So,
we have, that we can have, the most
we had
most important
a paper that we
using
worked
the
with
endoscopy application and also
with Michelle and Ratislav.
So I will talk about now about malignant biliary structure intervention. So this is a little bit how we can deal with this kind of problems. So when we have a proximal ilar malignant biliary obstructions, so we have ERCP plus brush plus minus biopsy. So we can use biopsy forces to take biopsy from the biliary tract. We can use cholangioscopy plus biopsy in certain unities when you have DAPS confocal and US. But you can use also percutaneous cholangioscopy if altered anatomy, for example. Even the same for distal malignant biliary obstruction. In some cases, we need it. However, most of them, 98% is solved by ERCP or cholangioscopy or US FMB. Surgery when feasible. Non-surgical candidates, what we need to do is ERCP, the gold standard, plus metallic stents. US drainage, if papilla is non-accessible or failed ERCP. It could be a hepatogastrostomy or anterior drainage. We can use percutaneous, biliary drainage, and we can use hybrid techniques. It means we can combine all these techniques in some cases. So this is recent guidelines from the British Society for Gastroenterology. I believe it's very interesting. So they recommend when operable, when we have patients with operable distal malignant tract obstruction, should undergo a combination of endoscopic ultrasound, endoscopic, and ERCP to try to confirm a malignant histological diagnosis before proceeding to surgery. This is a very strong recommendation. However, the quality of evidence is low. Patients with this malignancy, with distal malignancy and inoperable disease from distal cholangiocarcinoma should undergo to an US/ERCP or ERCP alone to confirm pathological diagnosis and have their jaundice palliation treatment. There is a strong recommendation with a strong quality of evidence that is high. So patients with cholangiocarcinoma should have a malignant, distal malignant obstruction should have a fully covered self-expanded metal stent placed, because plastic stent should not place it for long-term palliation of jaundice. And the quality of this is a strong recommendation with quality of evidence high. And in patients that cannot have a stent placed at ERCP, we recommend US guided biliary drainage. This is a strong recommendation with quality evidence high. At present, the use of adjunctive endobiliary radiofrequency ablation and photodynamic therapy is not considered a standard of care for patients with hilar and distal cholangiocarcinoma receiving palliative care. For them, this is a strong recommendation with quality of evidence high. So we need more data about radiofrequency. And inoperable per hilar cholangiocarcinoma, proximal malignant tract obstruction, and jaundice should be considered for palliative stenting by either ERCP or percutaneous. That is a strong recommendation or strong quality of evidence that is moderate. The guidelines of 2022 from ESGE are very similar regarding those ones that I already mentioned. So I will talk about ERCP as the initial therapeutic approach. I believe most of the centers worldwide in endoscopy that perform ERCP, it gives us a lot of information, not just information about what is happening with our patients, but also the diagnosis. We can have a good diagnosis and we can treat many of at least 85 or 90% of patients with these lesions. So it allows us to perform cholangioscopy also at the same time and to have a good diagnosis and also an immediately treatment. As you can see, good drainage of the biliary tract in case of malignant obstruction, like this case, in the hilar segment. What about US guided biliary drainage? Can be an option when ERCP is not feasible. US biliary drainage has been used for unresectable cholangiocarcinoma with a technical and clinical success rate of over 90% and over 70% respectively. Main techniques in malignant distal biliary obstruction are represented by cholecystogastrostomy, cholecystododenostomy, and choledochododenostomy. So this is an example of how we can deal with these patients. I don't know if I can. So you see, we go inside the biliary dilation, the biliary tract. So we are from the left side of lobe. Now we can do also from the right side. We pass our guide wire, then we make a fistulotomy, and then we place a stent, as you can see here. So we can make from different place, this is choledochal antrostomy. This is an example using Axios. From the duodenum, for example, we can do a very good drainage. And in some cases, we can use alternative draining methods using, for example, lamps in intrahepatic biliary drainage. And you can see here very good results. But we can use also combining technique. That is that I always said we need to have a good drainage from the biliary tract. In this case, for example, the left side was not well drained. And you can see we put an Axios here in the intrahepatic to the stomach. And we had a very good result with this patient. So this is an interesting paper recently published about what kind of stent we need to use it. Well, the recommendation, it appears that partial cover stents have less time, more time to have a recurrence compared to fully covered stents. This is a study from the Italian group regarding the other things like adverse events or migration. For example, just migration in fully covered stents is more than in partially covered stents. So it's probably we need more studies to really confirm these results. However, this is a meta-analysis, and probably we need to use more partially covered stents. We talk about radiofrequency ablation. So we use a catheter probe to deliver thermal energy to the malignant tissue, followed by locoregional coagulative necrosis. And it can be delivered by percutaneous or, also by ERCP. So this meta-analysis showed a very good results of radiofrequency, and it showed that the difference, statistical difference, is more in the survival time between the groups, those that were under radiofrequency and a stent, versus a stent alone. So it's the conclusion is that it has a significant survival benefit from malignant biliary obstruction. However, we need more studies. I want to so in the future we will see this kind of therapies. In this case, for example, I already made radiofrequency, and I passed my cholangioscope just to see what is going on and if the radiofrequency was well done. And then you can see here that that was a very good result. And we can probably in the future, well, for sure, we will start to make this kind of, through the cholangioscope metallic stents to see under direct visualization the treatment of, the deployment of this kind of stents. You see here?
Thank you for the attention.
And you can see very well after the
DDW, ASG Live.
place. I don't know how I can continue. So in some cases, I think I need to change. In some cases, when we cannot,
afternoon,
we have the diagnosis and we cannot reach, we can make integrate the stents. Means we can place it just by US directly through the stomach, and you can see here the duodenal lumen. And we start to deploy the stent, and you can make a very good treatment in
this is so
these
bad.
cases.
My coordinator is not good. August 22.
So there's a other kind of alternative for these lesions. So we have also US guided transhepatic biliary drainage, as I already showed it to you. And future directions probably is to have intrahepatic biliary drainage guided by lamps. So like similar to EDGE, we can have we can make a cholangioscopy guided by US. This is I believe it's a hybrid technique, so we can use in combination, and we can see inside the biliary tract. So so here, for example, we made
there.
an
Okay,
axis
perfect.
with the Axius. You can see the standard Axius, 10 by 10. And you need to have a big dilation of the intrahepatic biliary tract and near to the
Now is
to the stomach.
I will do
So
a
once
drainage
you are there, we can pass a cholangioscope
back
through the stent
US.
just to see
So this is
what is going on, because this patient have alterated anatomy. So you can see here.
scopes.
So you can see the
imagine if we can
cholangioscope
arrive to do
going through the
to put,
lesion, and you can
this is
see
a
here the
cholangiocarcinoma.
neovascularization
This
and
is
destruction.
neovascularization
And then
area.
you can take
You can
biopsies,
see this is
and
the
finally you can put an stent for treatment this situation of the patient. And also it was an obstruction of the cystic duct, so we made it a gallbladder drainage. I need to switch. I'm sorry. Try to. So future directions, we can have also direct intrahepatic biliary drainage without lamps. We have a case series, almost 30 patients do it. So you can dilate. You don't have to be afraid about, biliary leak. So you can go inside with the cholangioscope and see if there is any, residual cancer after surgery, for example. And in the future, we will see a little bit more difference, cholangioscope, as my good friend Sandeep showed it to us. So in this case, I don't know, it's not, I'm sorry. In this case, for example, we used a 7 French cholangioscope with AI to see, not just
here
the obstruction, past the obstruction, and
for this is
and you can see here
with this see my guy wires here
how these technologies
and I
can
want
help
to
us
go
to
in
better deal with
few
our
years,
patients, but also
see
it was already
even for
published
this
in
one?
Video GI recently in this year. For us, you
French?
can see you can go inside the whole biliary tract. You can go in deeper areas that normally we cannot achieve, with the standard cholangioscopes, more than 10 French or 9 French.
Complete
So
is not good.
probably in
I'm
the future
sorry.
we can have a better evaluation of the biliary
We'll
tract
start
with this
to
kind of technology.
commercialize this. You see, so I explain.
So this is my take-home message. So imaging of malignant biliary obstruction includes non-invasive and invasive techniques. Artificial intelligence and confocal may assist in the diagnosis and decision-making process of malignant biliary obstruction. Management of malignant biliary obstruction includes ERCP, PTBD, US, and cholangioscopy or combining techniques. Currently, ERCP continues to be the standard treatment of choice for malignant biliary obstruction. In specialized centers, US biliary drainage has emerged as an alternative diagnosis, I believe, also, but also treatment in patients with ERCP failure. Once again, invite you to our courses this year. You can go, in May, presential, but online also in August. Thank you so much for this attention, and thank you for this invitation.
Thank you, Carlos, for that great talk. Our next speaker is Dr. Josh Obak, who's coming back to the podium to talk about prevention and management of ERCP complications in 10 minutes.
You got it. So good morning. It's my fourth lecture for this conference. I still have no disclosures to make. So I don't know why the font's so messed up. I apologize. This looks like it didn't translate well, but endoscopic retrograde cholangiopancreatography was developed in the 1960s for diagnostic purposes of the pancreaticobiliary tree. And honestly, with the advent of MRCP, endoscopic ultrasound, and more advanced non-invasive imaging, rather, it's transitioned to an indispensable interventional endoscopic procedure for the treatment and management of biliary and pancreatic disorders. And the range and incidence of adverse events for ERCP is substantially different from other endoscopic procedures and should be treated as such. And if you're going to perform ERCP in your practice, you need to be comfortable with the potential for adverse events. Major adverse events for ERCP include pancreatitis, bleeding, perforation, infection. And this is from the lexicon of the ASGE, which has helped us kind of categorize which are the major adverse events that can happen during these procedures. And you know what? I apologize. I don't think this is the appropriate slide set. This is going to be really disheveled. So I know we had a long situation here, but if I could just take a 2-minute break to give them the right slides, because this is not going to come out well. This is going to look bad. This is all going to be. I'm looking at the next slides. It's going to be very disheveled. So if we can give a 90-second break, I apologize. Give me 1 second.
No problem. Yeah, actually, yeah.
Okay, why don't we move to the debate and then we will catch up with Josh afterwards. So I'm going to invite to the stage Dr. Doug Adler, who's director for the Center for Advanced Therapeutic Endoscopy here in Colorado, where he's also a professor of medicine. He's the editor-in-chief of GIE, and he's going to be our first speaker, and he's going to be debating against Dr. Sandeep Takia, who's the director of endoscopy and EUS at the Asian Institute of Gastroenterology. So we'll have Dr. Adler come up first. Thanks, Doug.
Okay, thanks, guys. So in the modern era, we find ourselves as endoscopists called on to drain gallbladders very, very frequently. This is actually something we do in our practice all the time. We do both transmural and transgastric drainage quite frequently. And I asked my my opponent in this debate which one he wanted to do, and he said, "Oh, I'll do transmural because it's probably sexier, I guess." But so I'm going to do the transcystic side of the coin. So again, we tend to do these in poor surgical candidates, patients with malignancy. We mostly see them in patients with cirrhosis or poor cardiac status. You can go, if you're going transmural, you can go transgastric or transduodenal, or you can go transcystic by regular old ERCP. If you're going to do it the transcystic route, it does take a little bit of patience. Sometimes that can be a difficult thing to get a guide wire all the way into the cystic duct and up into the gallbladder. You need a really good cholangiogram. You need to identify the cystic duct origin and be able to get into it. And sometimes that cystic duct origin may be very, very small or at a disadvantageous location. It often may be obstructed, as many of these patients often have cholecystitis. Right now, if they have cholecystitis and the duct is obstructed, you can often get through it into the gallbladder anyway, but just recognize that it's going to make things difficult. And again, that cystic duct orifice could be easy to find, right? A lot of times when you don't want it, when you're cannulating an ERCP, that wire seems to find its way right up the cystic duct. But if you want to get in the cystic duct, right, that almost never, ever happens. So you can use any guide wire you like. I prefer 2.5 wires for almost everything in ERCP. There's really no data to support one guide wire over another. You can use a stiff wire or a floppy wire for these cases. If you use a stiff wire, it's more pushable, but there is more of a risk of tearing the cystic duct. And if you do enough of these cases, trying to do a transcystic ERCP, you will tear somebody's cystic duct, and that may completely foul your procedure and end your attempts at draining the gallbladder endoscopically. If you use a floppy wire, it may have much less pushability, but it's probably safer to use in the cystic duct. Remember, your cystic duct might just be 1 or 2 millimeters wide. Which stent to use? I do quite a lot of these transcystic cases and people who can have transmural access. And I almost virtually every single time I use double pigtails. And a lot of times a 5 French double pig is really all you need, right? A 5 French or a 7 French will get the job done. If you use something bigger, an 8.5 or a 10, number one, you usually don't need that. Number two, it can be a real struggle to get that up there. And number three, you may have to dilate the cystic duct to get anything bigger than a 7 French up. And sometimes a 7 French stent needs dilation. We recently had a case where we opted for a 7 French and it turned into quite a struggle. And, you know, halfway up, we kind of realized like, gee, we should have used the 5 French stent. But again, all of these are ways to also perforate or tear the cystic duct. And this is kind of what it typically looks like, right? Here we are. You may notice that I flipped the fluoro compared to some other people. So the guide wire goes up my cystic orifice, out to the right, and you've got a nice coil there in the gallbladder. And this is really what you want. The wire can't be halfway in. The wire has to be fully, deeply in the gallbladder and coiled, and then we'll leave something like that. That's a 515 double pig. That's all you need. And these people will have almost immediate improvement in their symptoms. When they wake up, they can feel the difference right away. Here's another one. This was a patient who had a cholecystectomy, didn't realize that they had left a significant gallbladder remnant. This is full of stones, and we were able to get up there through very, very narrow cystic duct. And even with a tiny little gallbladder remnant, we were able to place a pigtail fully in there. And this patient went a subsequent completion cholecystectomy after his cholecystitis in the remnant had resolved. He was really annoyed to discover that he still had a gallbladder and had to have a second cholecystectomy. Yet another one showing some tortuous cystic duct anatomy. You can see my wire makes a full 360 turn in the cystic duct before I'm able to access deep into the gallbladder. And you can see that there's multiple stones in that gallbladder. And my stent, again, this is a benefit of a 5 French stent. My stent was able to also maintain that full 360 loop in the cystic duct and get into the gallbladder. Just 1 or 2 more just to give you a sense of stuff. They're all a little different. Like all these cases, you got to kind of figure out where's the orifice. Is the cystic duct long, short, tortuous, straight, right? Because you're working through the valves, right? The valves of Heister in the cystic duct. Here again, you can see a lot of wire coiled very, very far out into that gallbladder. Another 515 here. And then this is what it looks like endoscopically. And right away, you'll see drainage through the side holes of the stent. You can do more than 1 stent. In my experience, that's really not necessary. 1 is kind of all I usually aim to do, and we have very, very good results with that. On rare occasions, you may need cholangioscopy to either identify or access the cystic duct orifice. It depends. It might just be in a really bad place. It might be obstructed. It might be swollen. I would say that we tend to do this about 5% of the time or less, but once in a while you need it. And for example, here you can see the cystic duct is all the way on the left there. And we just were not getting it without the spyglass. And then with the spyglass, it's a 2-second operation once you identify that orifice. So there's a lot of pros to transcystic drainage, right? You'll need to be able to do EUS to do it, right? There's still a lot of people who are ERCP trained who are not EUS trained, right? If the patient does undergo a subsequent cholecystectomy, like maybe they're not a cholecystectomy today, but maybe they will be down the road, it's technically much easier for the surgeon to do the cholecystectomy down the road. They can just take out the chole the regular way, pull your stent on the procedure, and you don't even have to follow up. It just uses existing ERCP tools that you have on your shelf. Critically, you can do this with any INR, and many of these patients are very, very bad cirrhotics with elevated INRs that can't be corrected. You can do this with any platelet count. Platelets less than 50, you can still do this, right? You can do this in somebody with significant ascites, and you can do this no matter where the gallbladder is located. Whereas with transmural approaches, you're limited. That gallbladder's got to be next to the stomach or next to the duodenum, right? Downsides are provides gallbladder decompression, but we can't use this to remove stones. These stents, if these are never surgical candidates, require periodic maintenance. You may fail, right? You may not be able to get that guide wire into the gallbladder, and you may not be able to get a stent into the gallbladder, even if you get a wire in. Van Riet and I were talking earlier, and it is worth mentioning too that this is a lot cheaper than placing an Axios stent, right? Because this uses a $150 plastic double pigtail as opposed to as a $5,300 hot Axios stent. So there's that to consider as well. Transmural drainage, again, rapidly decompresses the gallbladder. I like to use 15 or 20 millimeter Axios for these. You can do it without fluoro, without a wire. It's often one-stop shopping. But again, it's not for everybody, but it does give you access to the gallbladder if you need to remove stones. Downsides to transluminal drainage, again, you basically need a normal INR. You basically need normal platelets. Very, very hard to do this if the patient has bad ascites or poorly controlled ascites. And again, that gallbladder's got to be there. And I've done a lot of Axios gallbladders, and sometimes no matter what you do, you cannot get that gallbladder close enough to reach. So that can be frustrating. So this is a photo of me and my opponent just sort of discussing this topic right now. So I will turn it over to him. But again, it's important to recognize that both methods exist for a reason. I think a lot of people don't think about the transcystic route. It's not as kind of macho. It's not as sexy. It's not as kind of cool. But for a lot of patients, it's a really, really good option. And it's always good to keep your surgeon in the loop on this decision. Thanks, guys.
Thanks, Doug. Okay, Sandeep.
Thanks, Rag. That was a wonderful talk, actually. You did part of my job too. So the debate is, in this kind of scenario, you need to drain the gallbladder, whether you need to go transpapillary by ERCP or transmurally, either to the duodenum or the stomach, depending where the gallbladder is located. So touching up a few things or repeating a few things, indications of endoscopic gallbladder drainage is that when patient has acute cholecystitis and is a high risk for a surgical removal, or if the patient already has a percutaneous catheter inside and now you want to internalize it, or if the patient also has a malignant distal biliary obstruction, where we traditionally do ERCP and that's not possible. EUS guided biliary drainage also is not possible. For example, it's a duodenal narrowing, or you're not able to get your right angles to get the CBD or the EGS. In these scenarios, one can consider doing a gallbladder drainage. This is a very good review article. I would like all the fellows to go through it, which came from Tadbaran and NEGM way back, but it's very good. So in non-operative candidates for the gallbladder surgery, those who have high risk can have either of these three things: transpapillary, percutaneous, or transmural drainage. As the surgical risk increases, we can consider these options. And endoscopic methods of drainage include, as Doug said, is transpapillary, where you place plastic stent, and sometimes you actually place a nasocystic tube into the gallbladder as well, and kind of decompress it temporarily, and also use that as a method to drain internally using a transmural. By transmural, you can actually do both methods depending on duodenal is preferred by most operators, but even stomach can be used as a route of entry. So what are the advantages of per oral transpapillary is that it does not require external catheter, can be performed in patient with ascites and coagulopathy, as Doug said, and can be done simultaneously for a patient who has a bile duct stone. You do a clear up the bile duct stone, patient also has acute cholecystitis, and if the wire happens to go into the cystic duct, you can place a transpapillary cystic duct. But it's very technically difficult. It's not very easy to place a guide wire. It's more by accident than by intent. Whereas EUS guided drainage allows placement of a stent with larger diameter, so not only drain infection if that's the indication for drainage, but you also allow stones to drain out if you're using any of the routes. So small stones can drain out and big stones can be addressed if required using an endoscopic lithotripsy. but it is little expert dependent and it's not widely available, expensive stent, rightly said. But some of the advantages with transmural drainage offers is that it's easy to place and it's very safe. Several indications can be addressed to by EUS guided transmural drainage. For example, non-surgical candidates who are not likely to become surgical candidate even later on. You can also remove stones if required. It can be a bridge to a surgical cholecystectomy. That patient is so sick that is unfit for surgery, drain him, get better. A month later, you can do a cholecystectomy, and it does not affect a surgical procedure. You can convert a percutaneous drainage into internal drainage by EUS, and patients where EUS ERCP guided is not possible, or PCC is also not possible, you can actually do this one. And there are several methods of doing gallbladder drainage. It's just not single straight on freehand technique. I'll just describe those. Whereas transpapillary drainages by ERCP, it should be considered when you're doing a CBD stone removal and you happen to go into the gallbladder in a patient who is likely to be a surgical candidate for future. But the disadvantages with this method is that the cannulation of cystic duct is more technically challenging and often by accident and not by intent. Sometimes we require cholangioscopy if you really want to go in, and that prolongs the procedure. He's anyway a high-risk patient, and you're prolonging the procedure by cholangioscopy. And I'm glad Doug said that it's less than 5% in experience he uses that. These stents do get blocked, and whenever either you change them every 3 monthly, which is a big exercise for a patient who's living longer, or you do that when the patient has symptomatic, when the stent get blocked. Either way, we need a repeat procedure sometime in life to follow. And when they require removal, if you may not enter the cystic duct again, and it's unfit for a sick patient again. There are some publications on this front addressing this. Is Shan Irani's group, which has published that EUS GB drainage versus transpapillary cystic drainage of the gallbladder. It's highly technical success and low recurrence rates of cholecystitis if you go by the EUS route. Whereas transpapillary drainage, that is ERCP, can be considered as a first-line therapy in patients who are surgical candidates but requiring temporizing measures, or you're doing an ERCP for some other reason, that is removing the bile duct stone, and then you go into the gallbladder and then drain that out. There's one more publication which Carlos published. Carlos, you can look at the paper. This is prophylactic EUS-guided gallbladder drainage prevents acute cholecystitis. So patient who has obstructive jaundice because of distal malignant biliary obstruction, you have an option of directly draining gallbladder in addition to other methods of biliary drainage to prevent future cholecystitis. So in this single center study, unresectable malignant biliary obstructions, occlusion of the cystic duct can happen, and prophylactic EUS GB drainage demonstrated a reduced incidence of cholecystitis in the patient who had this procedure versus those who had only transpapillary ERCP drainage with metal stents. How do we do this procedure? So there are three methods broadly. One is a Seldinger technique where the gallbladder is distended. It's tumor blocking the neck of the gallbladder. So you puncture the gallbladder just like a pseudocyst, pass the guide wire, coil it inside, create a fistula, and then you can place a lamps. Or if you're using a hot lamps, you can actually go over the wire and place your stent inside. So this was a cold lamps technique, but now with hot lamps, you can just place wire and then burn your way in. The other method is somebody who has a percutaneous drainage of the gallbladder. You can convert to an internal drainage later on. This was a patient who had a bilateral metal stent 2 months back, and he comes with acute cholecystitis. He had a PCC because he was too sick. And then once he became better, he did not want the tube. So we used the tube to inflate the gallbladder. So the landing space for the lamps is now better. And then we place a 15mm lamps inside. Once it is nicely done, then you can take out the percutaneous catheter. So that's another way of tackling this thing. So this was the patient's X-ray. And this was the final procedure. The third and the most common method of drainage is a freehand technique of the gallbladder drainage. For this, you need a distended gallbladder. So good landing space is required. It should be close to the duodenum or the stomach. And I agree with him that sometimes it is difficult to find a closed space, but if you spend enough time, you may find one as you find it here. You're going through the gastric wall. And once you open the distal flange, then you can pull it back towards the route of entry, and here comes the pus. in a patient who had severe cholecystitis, along with some stones also leaked out. And as the stent expands, even the gallbladder stones also come out, and you can have a cleaner gallbladder much later. This was a multi-center experience from the Italian group, and they showed the technical success very good, clinical success very good. Mean hospital stay is much shorter than expected. So in the end, I would like to conclude by saying that EUS gallbladder drainage or transmural drainage is an option for non-surgical candidates, those who have high risk for acute for surgical removal of the gallbladder, say acute cholecystitis, or if they have malignant distal biliary obstruction. It can be a single step EUS guided hot lamps if the gallbladder is distended. This is a very simple procedure and can go very nicely. It's inching towards a prime time drainage of the gallbladder now compared to any other method of percutaneous or transpapillary drainage. It's possible, but ERCP guided drainage is often unpredictable, but some of the experts can do it. I would like to introduce my team here who are doing the EUS and part of the gastroenterology team. Thank you very much for your kind attention.
Doug, do you have a rebuttal? Did either of you present? Want to present? All right. Okay. We'll take a vote then. How many in the audience thought that Dr. Adler won that debate? Raise your hand. Oh, no. How many thought Dr. Laktakia won the debate? Oh, all right. I think, first of all, but I think that means he gets $100 Visa gift card now. So, all right. Okay. All right. Josh Obach, you ready to give your talk on minimizing pancreatitis?
ERCP complications.
Oh, pancreatitis, one of the ERCP complications you're going to minimize. Oh, man. All right, Josh, just do it by memory.
Okay, let's close this down. So I don't see that on my screen, so I'm going to step over here. And I'll just, that's fine. So good morning, everyone. We're going to talk about prevention and management of ERCP complications. Next slide. So we were saying ERCP is an old technique used for diagnosis originally, and now it's an indispensable therapeutic procedure for advancing pancreatic or biliary disease. Next slide. Thank you. Oh, perfect. And so when we talk about major adverse events in the setting of ERCP, the ASG has a lexicon to categorize adverse events, including pancreatitis, bleeding and infection, and perforation as potentials for adverse events, for major adverse events in this setting. And so they've categorized them as mild, moderate, and severe based on the severity of the adverse event that has occurred. Next slide, please. So for post-ERCP pancreatitis, this is by far our most common and most dreaded complication that can happen in the setting of ERCP. It is the most common and it accounts to over $150 million annually for healthcare costs. And post-ERCP pancreatitis admission rates have increased by about 15% from 2011 to 2017. And when we consider post-ERCP pancreatitis in patients who have had an ERCP, it should be considered if there's abdominal pain with transaminase or amylase elevations greater than 3 times the upper set of normal within 24 hours of the procedure, and a requirement of admission or prolongation of a planned admission for a patient who's already been hospitalized. The overall incidence has been quoted between 3.5% and 9.7%, but it really varies based on a patient's risk profile, with the majority of post-ERCP pancreatitis being mild to moderate in nature, and less than 1% being severe pancreatitis that can lead to end organ dysfunction or potential death. And so we're all relatively familiar with relative risks associated with pancreatitis. There's been multiple studies that have shown associations of either patient-related factors, procedure-related factors, and operator-related factors. When it comes to patient-related factors, you can't change that. I think the best thing you can do is try to avoid patients if they have a marginally indicated ERCP, but just recognize that there are certain patients such as female sex, younger age, previous ERCP pancreatitis, normal LFTs that may increase the risk of developing pancreatitis if you are to pursue that procedure. From a procedure-related standpoint, there are multiple things that we can try to mitigate, such as reducing pancreatic duct injection, repeated guide wire entries into the pancreatic duct, difficult cannulation, so improving your technique, and avoiding papilectomy or pancreatic sphincterotomy or monopapillar sphincterotomy unless it's absolutely necessary. And then in terms of operator-related factors, training involvement, hard to avoid. And then low case volume. As a practicing endoscopist, if you're not doing these over 200 cases a year plus, you really shouldn't be engaging in ERCP or just dabbling in ERCP to avoid these types of complications that may occur. Next, please. So when we talk about post-ERCP pancreatitis procedure-related factors, difficult cannulation is one of them. I know we've talked about this prior lectures here, but it's really considered difficult if there's greater than 5 attempts or you're trying to cannulate for over 10 minutes or 5 to 10 minutes of trying to cannulate the ampulla. And this increases the odds of developing pancreatitis by about 2.4 to 2.8. And so orientation matters. Next, please. So when you're looking to position yourself, you want to get your duodenoscope really low down in the duodenum underneath that ampulla. Next, please. To try to go in an upward trajectory to follow that biliary segment, if that's the duct of interest that you're going into. If you're going en face right into the ampulla, you're going to wind up in the pancreatic duct and possibly cause pancreatitis or inadvertent ductal cannulation and distortion of the pancreas at that time. Next, please. Moving on, in terms of when you're trying to cannulate, there's multiple studies that have supported guide wire assisted cannulation over contrast assisted cannulation. So just to put the tome into the ampulla or papilla and start injecting contrast is not recommended. You really shouldn't be doing that to try to see where the orientation of the ducts are, because this does increase your risk of developing pancreatitis versus wire guided cannulation, which is usually less traumatic, 1, and 2, does not run the risk of causing inadvertent pancreatic ductal contrast injection. But in the hands of skilled endoscopists, gentle contrast injection in some studies, if you're able to cross over from wire-guided to contrast injection, does not necessarily increase the risk, but blatantly just going in there and injecting contrast is not recommended, and we should be avoiding that. Next, please. And then pre-cut sphincterotomy has historically been thought to be a risk factor for post-ERCP pancreatitis. However, the early studies have evaluated the pre-cut sphincterotomy primarily after a difficult cannulation. And so whether or not it was actually the pre-cut sphincterotomy or the fact that you're going toe-to-toe in the octagon with the papilla for 20 minutes, what's causing the pancreatitis? So honestly, there has been a great meta-analysis suggesting that early pre-cut sphincterotomy or fistulotomy, there is no difference in post-ERCP pancreatitis compared to standard therapy if done early on. So if you can either try to cannulate for 20 minutes or do a pre-cut sphincterotomy within the first 6 to 8 minutes, you probably were going to have the same risk of pancreatitis. And when they control for a non-trainee performance, early pre-cut sphincterotomy actually reduces the risk of post-ERCP pancreatitis. So in the hands of a skilled endoscopist, going to pre-cut sphincterotomy should be considered. Next, please. Lastly, endoscopic papillary balloon dilation without a sphincterotomy should be avoided. We know that this can increase your risk of developing pancreatitis, possibly due to ampullary swelling or pancreatic duct orifice swelling, and it can increase your risk for developing post-ERCP pancreatitis with an odds ratio of about 4.5. Interestingly, shorter dilation periods or durations is inversely proportional to your rate of pancreatitis. So if you have to dilate through the biliary orifice, going for 1 minute, not recommended. You should probably dilate over 2 to 5 minutes if possible to slightly reduce your potential risk of causing pancreatitis in these patients if you do not feel comfortable performing a sphincterotomy. But that being said, if you can make even a mild sphincterotomy, biliary sphincterotomy when you're doing dilation, that would be warranted over just doing sphincteroplasty. Next, please. So that moves us on to pancreatic stenting. Multiple medical meta-analysis have supported pancreatic duct stenting for pancreatitis prophylaxis and has shown to be a relative risk reduction of about 0.39. And just looking at 8 randomized controlled trials, that slightly increases the lower risk of developing pancreatitis in patients who are having a difficult cannulation or high risk for pancreatitis during the ERCP, with a number needed to treat to be 8. So if you're really dealing with a high-risk patient or inadvertent pancreatic ductal cannulations or frequent wire access to the pancreatic duct, placing a pancreatic prophylactic stent should be within your armamentarium. Next, please. Also, there wouldn't be a talk about adverse events without talking about pancreatitis prophylaxis with rectal NSAIDs. So we are all hopefully are familiar with the 2012 landmark study by Al Munzer's group down in South Carolina with a multi-center randomized controlled placebo-controlled blind study of over 602 patients who were considered at high risk for pancreatitis. In that group, there was over 75% who had sphincter Vodi dysfunction, and they were also 80% that were female. And what they found was that post-ERCP pancreatitis rate was about 9.2% in the indomethacin group versus about 17% in the placebo group. But in that study, over 80% of patients in both groups received a prophylactic pancreatic stent during the procedure. And so even in patients without stenting, there was indomethacin reduced the rates of post-ERCP pancreatitis from 20.6 to 6.3%. So this generated the question whether rectal indomethacin alone is sufficient versus combination with pancreatic stenting. Next, please. Which leads us to the stent versus indomethacin trial. This is a decade-long trial that was recently published in The Lancet in January of this year. And it's a multi-centered randomized non-inferiority trial. And during this study, there's over 20 centers, over 1,900 patients at high risk for post-ERCP pancreatitis were randomized to receive indomethacin alone or indomethacin plus pancreatic duct stenting. And what they found, there was a non-inferiority trial with a 5% in margin. Next, please. And what they found was that the rate of post-ERCP pancreatitis was 14.9% in the indomethacin alone, and that in patients who received stent plus indomethacin was 11.3%, with a confidence interval spanning 0.6 to 6.6, which was not significant for non-inferiority. So what this means is that indomethacin is not non-inferior to pancreatic stenting plus indomethacin, and in a post-hoc intention to treat analysis, indomethacin alone was inferior to combination with pancreatic stenting. Next, please. So we should be considering prophylactic pancreatic stenting in high-risk patients in addition to indomethacin. Indomethacin alone has been suggested not to be sufficient for your prophylaxis. That leads us to hydration. We all know that hydration is a landmark or a pivotal column in supporting patients with acute pancreatitis, and has also been implicated in the prevention of acute pancreatitis. There's been multiple studies and meta-analyses regarding post-ERCP or pre-procedure hydration or intra-procedure or post-procedure hydration to prevent post-ERCP pancreatitis in patients at high risk. And in this meta-analysis, they found that aggressive hydration reduced post-ERCP pancreatitis by 56% versus standard hydration with plasma-light solutions. There was no significant difference in adverse events with fluid overload or post-ERCP abdominal pain, and the number needed to treat for aggressive hydration in these patients to prevent one episode of pancreatitis was 17. And you can see the protocols that were used in a lot of these studies over there on the right. So just to kind of reflect, standard hydration in a patient who's about 70 kilos would translate into about 250 cc's for an hour-long procedure versus about a bolus to a bolus and a half for a patient who would be of the same weight with aggressive hydration. Next slide. So this is stolen from the ESGE, or modified rather from the European Society guidelines. But this is similar to what we do at our institution. And so when you're thinking about an algorithmic approach for preventing post-ERCP pancreatitis in your practice, first you should think, can the patient get NSAIDs? And if that answer is no, then if there's any contraindications rather, if that answer is no, you should also say, is there any contraindications to receiving aggressive fluid hydration? And if both of those answers are no, the patient doesn't have heart failure, they don't have an NSAID allergy, they're not a dialysis patient, then we usually will start initiating fluids in the pre-op bay. Patients will start getting lactated ringers hydration before they come back to the procedure, usually at a rate of about 250 cc's an hour ballpark. And then during the procedure, we do provide in all comers for the most part, unless patients are extremely low risk, rectal indomethacin 100 milligrams per rectum. If patient does have a contraindication to high volume, then obviously don't start infusing them aggressively. You can start just hydrating them at a normal rate, but don't continue to bolus them during the procedure. And if that risk for post-ERCP pancreatitis is going up based on the procedural complications or difficulty in cannulation or other risk factors associated while you're doing the procedure, you should shoot to try to continue hydration as well as placing a pancreatic stent for prophylaxis. But this is kind of our algorithmic approach at how we handle things at our institution. Next slide, please. That takes us on to bleeding. Bleeding is a serious adverse event most commonly a result of biliary or pancreatic sphincterotomy, and it can be immediate or delayed. Usually patients will have, I don't see too many patients vomiting blood, but they will have either melena or a hemoglobin drops in their lab checks. And the overall quoted risk for bleeding from a sphincterotomy is around 1.3%. 71% of patients have moderate bleeding requiring transfusion, and about a third of patients who have post-ERCP sphincterotomy bleeding will have severe bleeding requiring multiple transfusions or possible need for intervention with interventional radiology or surgery. Next slide, please. Risk factors for this include coagulopathy, active infection, patients on anticoagulation or antiplatelet therapy, again, low endoscopist volume or technical expertise. If you see bleeding during the procedure or the length of your sphincterotomy incision or presence of a diverticulum, or using a pure cut current when you're using a sphincterotomy, using a blended current would have less of a bleeding effect as a rate of that. Next slide, please. I'm not going to go over the guidelines here, but the ASG has wonderful guidelines regarding anticoagulation and antiplatelet management for patients on antiplatelet therapy or novel oral anticoagulation therapy, and procedural risk assessment based on the procedure, as well as patient characteristics, including renal failure or stroke risk, etc. So if you're unfamiliar with these guidelines, I suggest that you do have them on your desktop and review whenever you're doing any type of procedure, including ERCP. Next, please. So to prevent this, obviously, you want to avoid a sphincterotomy. If it's not necessary, you can orient your sphincterotomy position for biliary sphincterotomy in the 11 to 1 o'clock position, and consider in patients who you can't stop their antiplatelet or anticoagulation to do a very tiny biliary sphincterotomy, 1 to 2 millimeters or about a third of their diameter, followed by balloon dilation for about 2 to 5 minutes. A retrospective series out of our institution suggested that there was no increased risk of pancreatitis and no increased risk of bleeding if this was performed versus just doing transpapillary dilation or not cutting the patient. Using a blended current, like we said, and then there is some studies to suggest that prophylactic hypertonic saline epinephrine injection about 2 centimeters proximal to the ampulla has been shown in small studies of about 60 patients to reduce the rate of post-ERCP bleeding in patients at high risk. Next slide, please. So for our management, obviously, if the patient's unstable, you want to make sure that they're resuscitated and reverse any coagulopathy as needed. And then diluted epinephrine injection into the apex of the sphincterotomy site is warranted and can sometimes be sufficient to stop bleeding at the time of the procedure. Sometimes you may need to go on to thermal therapy, coag-respirators bipolar or APC, which can be helpful as well. Balloon tamponade with a large balloon dilator or extraction balloon holding tamponade for 2+ minutes at the site of the sphincterotomy, essentially holding pressure on the bleed, can be helpful as well. Mechanical clips, if you think you can get to the apex well and stop the hemorrhage, is appropriate. And then if all this is happening and the patient is still bleeding, or you're really concerned about post-sphincterotomy bleeding and oozing is not stopping, placing a self-expanding, fully covered metallic stent to have continuous tamponade at the apex of that bleeding site is reasonable, although it can be somewhat costly and not the most cost-effective approach to deal with unless it's necessary. Hemostatic sprays and gels, or the fairy dust, as Dr. Siddiqui likes to call it, can be helpful as well in terms of stopping acute bleeding at that time. And then for severe bleeding, you may need to get your IR colleagues involved in terms of helping stop any type of hemorrhage from intraductal or post-sphincterotomy bleeding from the GDA. Next. Moving on to infectious complications, cholangitis. This is not super common. It's about 0.5 to 3% of all cases, and it increases the risk when you're combining this with percutaneous procedures such as transcutaneous biliary access, failed biliary drainage after contrast injection, incomplete stone clearance, if there's biliary stent obstruction or migration. Doing direct cholangioscopy can somewhat increase the risk as well. And really the highest risk patients are those who are immunosuppressed, our liver transplant patients, or our PSC patients, as we saw in yesterday's case. Really not going in and doing an aggressive contrast injection to fill the ducts to prevent retained contrast and possible abscess formation from retained contrast is prudent. So in these PSC patients, you should be using minimal contrast injection and try not to inject ducts that you don't think you can access to prevent retained contrast and infectious complications. And similarly with hilar malignancies, you could see a similar concern. So again, don't inject if you can't reach. Temporary biliary stenting should be performed if there's concern for incomplete drainage, and IR percutaneous drainage should be considered if you can't access these ducts. Next paragraph, or next page, slide, please. Cholecystitis is another possible complication that can happen. Uncommon, it's quoted to be about half of all ERCPs, or sorry, 0.5% of all ERCPs, usually in the setting of gallbladder stones. In one setting that we heard in our debate right over there was the fully covered metal stent placement across the cystic duct in the setting of cystic duct malignant involvement of the cystic duct can increase the risk of cholecystitis for anywhere between 2 to 12%, which has been quoted in prior studies. So that's one thing to consider. If a patient has a retained gallbladder and you're going to be placing a fully covered metallic stent, jailing off that cystic duct may increase the risk of cholecystitis. And I do quote my patients, if we are going to do that, that there is a potential for 5% risk of causing cholecystitis in these patients. Next slide, please. So there is one interesting study, a retrospective analysis, that suggested that prophylactic transpapillary double pigtail stent placement prior to placing a fully covered metallic stent can reduce your risk for developing post-stent placement cholecystitis. And this is something that I was implementing before the study came out, just based on intuitive data, but 32 patients with this situation attempted transpapillary gallbladder drainage, and they were 75% success rate. They found that in the patients who did have a transpapillary double pigtail stent placed prior to fully covered metal stent placement, their cholecystitis rate in the setting of this malignancy was 4.2% versus 21% in patients who did not have transpapillary or prophylactic gallbladder drainage. So something to consider if you are placing a fully covered stent and you can access the cystic duct without jailing it off, you can place a transpapillary pigtail stent prior to placing that fully covered metallic stent. Next slide, please. Lastly, I'll talk about perforation. When you're thinking about ERCPs, the Stafford classification is really used to dictate what type of perforations are present and how we should be managing them. So the most dreaded type is a type 1 free wall perforation of either the medial or lateral wall of the duodenum. Type 2 is a periampullary perforation that usually can be seen in the setting of sphincterotomy. Type 3 would be a bile duct or ductal injury, usually from instrumentation or wire duct access. And type 4 is retroperitoneal error alone without any evidence of an overt perforation. Duodenal perforations are infrequent, but they are alarming. Obviously, we don't want that to happen, and they become difficult to manage. But the management of the type of perforations that happen during ERCP is dependent on the type and the severity of what's occurring. Next slide, please. So when we think about perforations, specifically type 1 perforations, there's multiple risk factors there. I just want to highlight post-surgical anatomy. So patients with Billroth anatomy, Billroth 2 anatomy, or Roux-en-Y gastric anatomy, they have post-surgical kinks in the intestine, and when you're manipulating either a duodenoscope, having the wheels locked, or manipulating that scope in a torque position can lead to free wall perforation. And when I've seen this, it usually is in the setting of a post-surgical anatomy. Also, we sometimes will do cap-assisted ERCP in patients who have post-surgical anatomy. And if your wires are locked with that cap causing pressure near the ampulla, you may lead to a perforation, which I've seen those happen the most in those situations. Next paragraph. When to suspect a perforation? Type 1, well, if you obviously see a hole, that's a perforation, right? And then if there's potential abdominal distension or signs for abdominal intraperitoneal air, that should be concerning as well. Type 2, it's important to look at your fluoroscopy and always have a scalp film prior to doing your ERCP. So before you've even intervened on the patient, you want to know what their right upper quadrant looks like before you start instrumenting in that region. Seeing the kidney or free air in the retroperitoneum or highlights of extraluminal air around the biliary system is concerning that you may have a retroperitoneal leak from a type 2 perforation, and consider stenting in that situation. If you are concerned and don't really know if there's a perforation, having wire access and doing gentle contrast injection at the downstream ampulla to see if there's any leakage of contrast may be reasonable as well, and then performing transpapillary fully covered metal stent placement as necessary. Type 3, during your cholangiography or your pancreatography, if you see any extraductal leakage of contrast on fluoroscopy beyond the anatomic boundaries, that would be concerning for a potential leak as well. Next slide. So when we manage these types of perforations, it all depends again on what we're dealing with. Patients with a type 1 NPO IV hydration brought into microbial coverage and alert surgery if there's concern that you may not be able to take care of it. Next slide, please. So we should try endoscopic approaches to closure. So if you do see a free wall perforation, going in and trying to close with either suturing device over the scope clips, through the scope clips, whatever devices are at your retinal available and what you're comfortable with is reasonable. And then while you have fluoroscopy, trying to see if you close the leak using contrast injection through your scope is reasonable as well. Sometimes you may want to consider doing a nasogastric decompression if the perforation was severe and you are concerned that there might be a persistent leak, and alert your surgical colleagues as well. Next slide. Again. Alternatively, excuse me, if patients have a type 2 perforation, you could sometimes see the retroperitoneum at the apex of the sphincterotomy site, or concerned that you have gone beyond the boundaries of the downstream bile duct. If you see that with secured wire access in the biliary system, you should place a biliary stent. Also, if you aren't really sure if there's a perforation or not, the slide on the right or the image on the right, doing a gentle contrast injection while you have wire access to the biliary system at the downstream bile ducts to see if there's any leakage in that region is reasonable to confirm your suspicion. And if there's any concern at all, next slide, you can place a fully covered metallic stent to try to bridge that defect and allow the patient to recover. Antimicrobials and admission for observation is reasonable in this situation. And then for a type 3 perforation, I don't have highlights here, but if there's concern for ductal injury of the bile duct or the pancreatic duct, placing a stent above the level of the defect to prevent leakage of contents is absolutely reasonable as well. Next paragraph. So in summary, when we're dealing with post-ERCP complications, the way to avoid these complications is to avoid marginally indicated ERCPs. And then pre-procedural antiplatelet or anticoagulant management is prudent. So stopping anticoagulation or antiplatelets as able for patients with their risk assessment is something that we should be considering in all our procedures. You should be referring your patients to an advanced center if you're not comfortable with doing ERCP yourself. But high volume endoscopists for ERCP will have less complications because they do this more, and they're usually more prone to catch these adverse events and be able to handle them in an acute setting. We talked about the necessity for periprocedural hydration, and to consider that in almost all your patients if they have no contraindications to hydration. NSAIDs for all patients if no allergy at low to moderate risk is even appropriate as well. And then with the stent versus indomethacin trial, pancreatic stents for high-risk patients should possibly be considered even if you don't have strong pancreatic duct access prior to placing a stent. Prophylactic antibiotics for high-risk infections are necessary, and then be able to anticipate potential adverse events and be prepared to deal with them in settings of perforation if they were to occur. So sorry about that little hectic presentation. I appreciate your time and attention. Next slide. And I will conclude with that. Thank you.
Josh, thank you so, so much. You were even more engaging than usual TED Talk. So we appreciate you.
Not a problem.
Okay, we are going to take some questions and answers until 12:30. So I'm going to invite all the speakers from our session. So Jason, Carlos, Josh, Doug, and Sandeep to come up. And we're just going to run into lunch a little bit, but we will make sure you guys still have plenty of time.
All right, any audience questions?
Hey, Jason, this is a question about endohepatology. I think for this space to really expand and explode, we need total buy-in from hepatologists. And I wondered if you could review some of the criticisms you've heard from hepatologists, where you think some of the unwillingness is, because I think there is a lot of resistance there, and how you address some of those points, because we're still in our own institution very slow on the uptake to convince our hepatologists that this is the gold standard approach.
And Anna and I were saying same at our institutions as well.
Thanks, Tyler. Great question. So, when we started doing this research, thanks. Tyler, great question. When we started doing this research, I presented this at UEGW, and this was about maybe 10 years ago. And I had a hepatologist come up to me and actually tell me to stop doing this research. Absolutely, they were appalled that we were thinking about poking the liver with a needle and going into vessels. They thought it was outrageous. And so, and I think, so there's, I think a history of hepatologists being just very conservative. And, they've done just tons and tons of research on finding non-invasive ways to get answers to the questions that they have. And I think what a lot of them have come to realize now is, what we can offer them is really a lot of good information in a very safe way. But I think the hepatologists that really fear the complications of these procedures are the ones that are not really, believing in it. Even in our institution, when we were doing this research, our longstanding hepatologists really didn't feel that we were doing the right thing for the patient. Now he's completely flipped 180. And
Yep. I see so many questions up there, so I don't know if we'll have time for this
In
one.
person takes precedence, so.
Got it.
ahead.
Sounds good. So for the double pigtail transpapillary gallbladder drainage stents, when they're put in, I saw in the presentation there was a mention of replacing them like every 3 months or so. I haven't seen that in clinical practice. I know Dr. Sandeep isn't here, but the rest of the experts, if you do put a double pigtail plastic stent in, what I've seen is that you just leave it like till the person comes back with like issues with it.
Hi.
Yeah.
So, very good question. I think it's very difficult, to be honest, because cystic duct is sometimes really small. So in real practice, it's very difficult. So the best recommendation that I have is, so if the patient makes a cholecystitis after a stent, gallbladder drainage, that's all. Because it's easier, in less than 5 minutes, and you will solve the problem. So it's transpapillary. I think it was a very good indication where we didn't have we didn't have the Axios approach now or gallbladder drainage approach now. But if you can do it, yes. But we don't know. It's around 20% of cases that can perform a cholecystitis with a stent. So 20%. So imagine that you take 1 hour just trying to put the double pigtail because of that. I think I don't know. What do you think?
If you're doing an ERCP anyway for a stone, maybe it's worth trying, but I agree with you. Some people always make fun of me when I say it's not that easy. If the cystic duct's obstructed, like how hard are you going to push? How aggressive are you going to be? So in those cases, I think transmural drainage is something that we can do quickly. And then that goes to one of the questions that were asked up there. But what about those patients that are going to go to surgery? Sandeep said that LAMs can be used as a bridge to surgery, but I will say in the States, there's anecdotal evidence from the surgeon saying, it causes a lot of fibrosis. It's going to be hard to close the fistula. And if you're going to do it in the stomach versus the duodenum. So.
And sorry, in our practice, I agree. We also do transpapillary stenting if possible, if we're going to do an ERCP anyway, but you're 100% right, Uzma. It's not that easy to always find the cystic duct, taking the angle wire, rotating the C-armor if you don't have a fixed table, trying to find the cystic duct takeoff. And even if you do get into the cystic duct, are you going to be able to get the stent through? So, using a 5 French or a 7 French is reasonable, but I have, wasted time for an hour trying to get in and just saying, oh, this isn't going to work. And, with the lumen-opposing metal stent concern with fistulization, scarring, and things like that, if the patient's an operative candidate, let's not forget about our IR colleagues. That's an option as well. Not necessarily that patients want to have a percutaneous drain, but that's always a potential if they develop cholecystitis and they're a surgical candidate, and we don't necessarily want to do a duodenal drainage, and we can't do transpapillary drainage. You want to say something?
He explained it so well.
We have any other audience questions?
Yeah, sorry, I'm going to go back to endohepatology for Dr. Samartina. The excitement from the hepatologist is low because of their invasive testing, but I found interesting that some of the patient, you mentioned that the EOS data is more accurate than the FibroScan. Is there any predictors of the subset of these patients that will benefit more from the EOS comparing to the FibroScan? And the other question, was there any data to compare with MR elastography, which we know it's a little better than the FibroScan, and compare to the EOS as well?
Can you repeat the question again?
Yeah, I might need to get you to repeat the question again because these guys were fighting up here. So, so they're still, you know,
But you're just saying
hustling.
FibroScan versus,
So MR elastography versus EOS, and who are the patients that were more accurately assessed by EOS technology versus the FibroScan?
Oh yeah, great question. So we don't know yet. You know, this is pretty early on. The EOS processor that has the shear wave elastography is the Arietta 850, and so that's really kind of now just getting phased in. And so we have a 4-center study that we're going to do to kind of understand what the right protocol is for getting these shear wave measurements, because it's kind of operator dependent. If you push the big wheel a little too much, you know, your reading will kind of be off a little bit, and so we still don't understand exactly, you know, what the right protocol is. And so I think if we standardize it and then study it, you know, properly, we'll be able to figure this out. But I will say, it's so easy, you know, and now, you know, usually when I do an endohepatology case, in the beginning, you know, we're doing these courses, we're doing a lot of teaching. These were like an hour-long case to do a liver biopsy, a PPG, a shear wave. But now we've got everything kind of streamlined. We know exactly what to do. So for me, when I'm doing the liver biopsy, I'll have my nurse prepare the specimen so I don't have to leave the scope. And while they're preparing the specimen, then I'm doing the shear wave, and I'll do left lobe, right lobe, and spleen. And then by the time that's done, they're telling me, you know, how many centimeters of liver core I've gotten, and then we can do the PPG afterwards. So it's about a 30-minute procedure now to do all three. And so, so I think, you know, as the processors become more available, you know, we'll get the standardized protocol. We'll be able to answer those questions better.
Dr. Samartina, just a quick one. So after you do your EOS coiling and gluing of the varices, when you bring the patients back and follow up, have you found that some patients have developed new interval gastric varices post-treatment, and do you treat those?
So I have to admit, we don't actually do a lot of EOS guided coiling much. I'm not sure if others on the panel do, but actually, go ahead, Doug.
I mean, we do a fair amount of coiling. There's not a huge number of cases all the time, but we've done a decent number. And we haven't seen them developing other varices at other locations in the stomach. Usually it's pretty striking when you bring them back in a month. It's a very dramatic change.
At our institution, we've had at least 4 or 5 cases of new, pretty significant varices in the interim when they come back for the 6-month follow-up. So just wanted to...
So I have a big experience, more than 200 cases until now made it. And more than 3 years, 5 years of follow-up now. So we already, I think in DDW, we will have a presentation about our series. So, so the thing is, first, when it's, when there are isolated gastric varices, very difficult to treat. So you will have to retreat this patient for sure in less than 1 year. That is for sure. Second, when you do the treatment, after 3 and 5 years, you don't see any, you know, appearance of gastric varices. That you can see probably is more esophageal varices that can reappear. That's all. Is the only thing. But reappearance of other varices in other sites is not common. It doesn't happen.
we'll take 2 questions from the board. Carlos, so what position are the patients in when you're doing the gastric coiling
Oh.
and flu?
Yes, yes, this is supine,
And
yes.
then do you use it for rectal varices as well?
Yes, you can use it, yes. And for duodenal varices also. Once I was invited in New York with Dr. Cajela, and there was a very difficult patient in the third position of the duodenal part with varices there. So thanks to the technique, we achieved to stop the bleeding and stop the varices in that position. Yeah.
So we do our varices coilings prone, and Trendelenburg does help. Like if they're, sometimes like you'll see a photo from the prior person and it'll look great, and then you'll get down there and they're not as impressive. And if you just tip them on their head a little bit, they get impressive quickly.
Okay, one last question before lunch. Anything in the audience?
I just had a quick
Oh.
question, and it's a very boring one compared to all these other excellent questions. But I'm wondering what the rising cost of rectal endomethacin, when we first started using it, it was literally $50 and maybe less, and now it's a couple $1,000s or more. And I wonder amongst the panel if this has altered your practice at all in perhaps the non-high risk patients, right? The SVI study enrollment included patients who tried cannulating for at least 6 minutes, but otherwise they weren't eligible for the study anyway. So I wonder how you guys, maybe really quick answers, given the time.
So for our institution, we have our rate with our pharmacy. We get one dose of indomethacin is about $400. And you know, my feeling and my take on that is if it takes $400 to prevent 10 cases of 1 in 10 to prevent pancreatitis, that's a cost save. So for essentially anyone who's essentially not extremely low risk, we are giving prophylactic indomethacin with the understanding that our pancreatitis rates at our institution are between 2 and 4%, which is not that bad, and we're happy with that. So we're gonna hopefully continue doing that as long as we're seeing good outcomes like them.
We're giving indomethacin near universally. If they have elevated creatinine, and if they're extremely elderly, sometimes we'll either reduce the dose or hold it, but otherwise we're pretty much giving it to everybody. I think we're paying about $300 for 100 milligrams of indomethacin.
I still give it for every single ERCP regardless, but our pharmacy did reach out to me though, asking about an alternative compounded NSAID suppository that they wanted us to look into using because it was going to be a lot cheaper than indomethacin. So they never followed up on it. So for right now, we're still using Indo.
And I mean, after you brought that up to me, I think I'm a little bit more judicious about who I give it to. The lowest of the low risk, maybe I'll avoid it, but almost everyone else I'm still giving it to.
So I want to just to make a commentary about that. You know, you know my unit, and you also know my unit. So in Ecuador, it's very difficult to have indomethacin or any other thing. So what we have, I don't know why we have a lot of endoscopy technology, but some kind of medication we don't have. Well, what we do is from many years, because my center is ambulatory surgical center. So what we do is a lot of fluids before, during, and after. So 2 hours of ringer lactate, yes. And what we saw, the risk of pancreatitis from us is really low. And there was a study, a retrospective study that was an abstract just from an Ecuadorian institution, I remember, in one DDW. I don't remember exactly in what Congress was. The physician that does this passed away, but he showed that the patients, when you have, very good fluid before and during and after, you have less risk. I don't know. We need to do a prospective study to evaluate that. I didn't do it, but from my experience, our patients really have low risk because we follow up the next day with, with the laboratory data. So I think it's a good option. We need to evaluate that.
All right, I think we should adjourn and then everybody will go to lunch and then we'll be back at 1:15 for session 3. Thank you.